Okay, guys, thank you very much for coming, and thank you for inviting us here. I'm speaking on behalf of a bunch of guys that have come from London and London's Air Ambulance, and we've had a fantastic time here already, medically speaking and non-medically speaking. So thank you very, very much for having us here in Zermatt. We are going to talk to you about, so trauma is the topic, I think it says online. We're going to focus on hemorrhage, and the context to that is that all of us have slightly different job roles, but we all work for London's Air Ambulance in a system that is probably similar to many of your systems in some ways and very different to many of your systems in some ways. Some of you I met last night and we had a little chat about who does what and who carries blood and who does what procedures. But what it's worth telling you is, our service is a busy urban service, and it's an air ambulance that covers predominantly one team, usually one team, sometimes two teams, covering 10 million people in a big busy city. So we see a lot of trauma. On average, our aircraft and our car go to around about 5-6 cases per day or per 24 hours. And it's a mix of blunt and penetrating trauma. We see a lot of penetrating trauma because we're in London and everybody likes to stab each other in London, sadly. So some of the stuff we talk about is based on what we've learned there, but it's very applicable to all hemorrhage, and we see a lot of blunt hemorrhage as well. So that's us, that's our background. From what I understand from you guys, there's quite a big mix in the room. There's a hell of a lot of experience in the room, and most of the people I met last night, we were doing a little workstation in the back, have got a lot of experience in pre-hospital care, a lot of experience in intensive care and trauma and in and out of hospital, which was lovely to see. And I'm going to hope that we're not going to try and teach you stuff that you know already and go over the stuff that you've seen 100 times, because we've all got a lot of experience in the room. But we all consider ourselves reasonably experienced, but we're learning stuff all the time, and we've learned a lot over the last few years, and are still learning from the physiological data we're gathering from patients, and we'll explain why as we go along this couple of hours. But we're learning a lot, and we're challenging our own concepts on hemorrhage and exsanguination and cardiac arrest from trauma and vascular injury. We're challenging ourselves on a lot of that, and I want to try and share with you some of the lessons we've learned and gather from you some of your thoughts and your experience, and just maybe try and challenge what you know and what you think at the moment about hemorrhage and exsanguination. That's what we're going to try and do. We're going to base it all on cases because it makes sense. It's all about real cases and real patients and real physiology. And I'm going to start with a case that I'm going to give to you and then just leave hanging. But I want you to think about this case and then come back to this case after you've heard us talk over the next hour or two, and see if anything you think about this case changes, or if anything you think about this case doesn't change, and if so, how. For the purposes of confidentiality, this is a real case with real physiology from a real patient, but we're going to change it into this lot. So this is a dangerous bunch of people, right? These lot are out on the mountain, and there's an accident, okay? And there's two people involved in this accident. This guy. Now this guy, he's dangerous, right? The reason he's dangerous, because he likes to ski really fast, man. And he's a good skier, and he's fast, and he's in control of his skis. And he doesn't really like to go slow. He doesn't really leave much space on the piste, I have to say. And he doesn't really give you any other options when he's tanking it around the piste and you're trying to get around him. But there's this guy, right? He's a good skier. He's very fit, physiologically well. And then there's this guy. And this guy, he's really dangerous, right? Because this guy, he's a good snowboarder. Well, he used to be a good snowboarder. Well, he used to think he was a good snowboarder. And he was all right. He's pretty good. He never really mastered it as well as he should have done. He never really was 100% in control, but he likes to ride fast, and he likes to muck about, and he thinks he can do jumps and spins and tricks, and he's a bit too old for it, and he drinks a bit too much beer, and he probably shouldn't be snowboarding the way he snowboards, but he does. And it's been a long time since they've been out, and they're excited and they're riding around, and this guy comes flying down the side of the hill. This guy's going really fast, and this guy comes spinning off the side, loses it completely, thinks I might just about get away with this. This guy comes flying into him, and there's an almighty crash. High speed, really big mechanism, like to the point where everyone around goes, ooh. Someone's picking up their phone already to call for help because they know it's going to be bad. And so this is the mechanism, right? Skier versus snowboarder. Now, the actual physiology I'm going to show you is not a skier versus snowboarder. It's a case in London. There's not much snow in London, so it doesn't happen. But the physiology is the same nevertheless. So as you might expect, the snowboarder screaming his head off in pain, help me, please, help me, right? Making a lot of noise. He wants help, man. He's hurt himself, okay? He's hurt his shoulder. Something really, really hurts. The skier... yeah, remember this guy? Really cool, calm skier. Look at him, man. He's awesome. He's calm and he's quiet. He's really quiet. And he's really still. And he's not really making much of a fuss, okay? Now, you guys, let's assume that you guys work for Air Zermatt for now, right? You get called and you're sent, and I'm told that you guys can respond pretty quickly if it's local, right? 5-10 minutes after the injury, you're there. And the skier looks calm and quiet, and you ignore the snowboarder, man. He's making loads of noise, but you ignore him. You're more worried about the skier. Now, some might say that's prejudice. Some might say that there's some clinical gestalt that's going on there, or you might just not like snowboarders. I don't know. But what you notice clinically, and when you try and justify why you treated the skier, not the snowboarder, the reasons are: first, look at him. The snowboarder is screaming out. He's a good colour, right? You look at the skier, Robbie. He's laying really still, not making a fuss at all. Actually, his wrist looks a bit bent, but he's not complaining about that at all. He's quiet. His lips are really pale. It's the first thing you notice. You think, oh, doesn't look good. He's not moaning about his wrist. When you examine him, you check him top to toe as best you can. And he does say, you press down here, this is all okay. You maybe if you use a stethoscope out of hospital, you listen, his air entry seems okay. He's not really breathless. His air entry is equal, but when you press on his left lower chest, it really hurts him. And you can feel some crepitus there. And if you poke up in his left upper abdomen, just over his spleen, it hurts. Really tender. But, despite the colour of his lips, he's got a radial pulse. The rate seems all right. 95 is his blood pressure. If you measure blood pressure out of hospital, if you measure it, it's 105 over 42. Or if you want to go by a strong radial pulse, that's what he's got. So you don't like the look of him, and you think, do you know what? I think we probably need to just get moving with this guy. And you can tell me in a minute what you would do with this man in the time that you're dealing with him. But you want to take him to a trauma centre. You're worried about him. And actually, as you start to load him in the aircraft, and as you start to move towards your trauma centre, he gets a bit restless, he gets a bit irritated, he just looks like he's not quite right. And then you notice his blood pressure drops to 90 over 40. This is what you see on his monitor. And after that blood pressure of 90 over 40, it then improves. You get your volume resuscitation out. I understand it's Lioplas to start with here. You give him a little bit of volume because you think, oh, he's tender here, he's got pale lips, he's dropped his blood pressure. You give him a little bit of volume and already his blood pressure picks up. Look at that, 136 over 46. And his heart rate seems right, doesn't it? So you carry on. You're definitely going to a trauma centre. You're glad you headed towards a trauma centre. And you want to get there as quick as you can because you think, I might need some blood in this guy. He suddenly, just as you're arriving, you're very near to the helipad of Bern, is it? You notice he doesn't look good. He suddenly gets really pale. He starts pulling his mask off. He rolls his eyes. He says to you, I'm thirsty, I can't breathe. And he just gets really agitated, and he looks like he's almost going to get up off his trolley and start trying to get out the helicopter. He doesn't look good. And then he rolls his eye back and just lays back on the bed, semi-conscious. All I want to know from you is, what do you think? I don't want you to tell me now what you think, but I want you to keep in your mind a very clear picture of this person. What do you think is wrong with him in whatever that means to you, anatomically, physiologically, whatever. What do you think is wrong with him? And what are you going to do for him on the way to hospital and in hospital? And please think about it clearly as though you're writing it down on a piece of paper, because I want you to reflect back on this in an hour or two and think, look, has anything that these guys have told us changed what I think, or is it exactly the same? Do I know what to do with this guy? Is that all right? Okay. I'm going to hand over to Zain now. I'll let Zain introduce himself, but Zain's unusual in some ways. He's unusual in many ways, but he's a lovely guy. And the reason he's unusual is because he's a surgeon, he's a trauma surgeon, a vascular surgeon that flies on the air ambulance. And there's not many of those in our system, because there's not many of those that have done the anaesthetic training and have got the anaesthetic experience required to be able to intubate and anaesthetise people. So he's a gift to us, and he shares a lot that we wouldn't gain in our service without having a surgeon like him flying with us. So thank you, Zain, and over to you.
Hi, everyone, and thanks for that, Sam. Great to be here. Still a bit out of breath, just got off the mountain, so what an awesome conference. So, yes, I'm a surgeon, and I work for London's Air Ambulance. And what I'm going to do today is just really set up, my colleagues are going to tell you how we treat these kind of patients, and I'm just going to set it up by explaining some of the physiology that we see around bleeding and hemorrhagic shock. And just to be clear, I'm not talking about, all of us have seen a lot of hemorrhagic shock. I'm focusing on big sick patients. So the patient who's got 5 or 10 minutes left to live, gasping their last breaths, taking what Sammy was explaining, and then what's going to happen after that if you do nothing. So that kind of patient in your mind. Some people term it, refractory shock or profound hemorrhagic shock. So that whatever you call it, that group, irreversible shock, whatever you call it, that group of people. This work is being done by a lot of people. So just start off, I just want to acknowledge a few people. Most of it's done by my research fellow. So a lot of the pictures are done by him. He's done a brilliant dissertation on this that's published. His name's Carl Evans. And Robbie's done a lot of work with me. He'll be talking to you next. And also, how many people from Germany here? Is there a few? Yeah, good. So a lot of this work is pinned by a famous German physiologist, Otto Frank, famous from Frank's Darling Law. So some of his work that's kind of been forgotten, so we're looking at it again. Anyway. So hemorrhagic shock, nicely summarized recently in the New England Journal of Medicine. But even in there, the only description of how you land up shocked is blood loss. Is talk about blood loss, then you're shocked, and then all the repercussions of being shocked. So you get lactic acidosis because you don't deliver enough oxygen to the cells, and you get coagulopathic, and your cells are ischemic, and the tissues are ischemic, and that could lead to organ failure if you survive, or it could exsanguinate and die. And then there's this that everyone will be familiar with, the definition of shock that we're all happy with. I mean, very precise definition, nothing wrong with it. A clinical state characterized by inadequate delivery of oxygen and substrate to meet cellular metabolic demands. All I would say with this is that it really focuses your mind on the cellular and tissue level. And then we think about how to treat that as about how to better deliver oxygen, using inotropes, fluids and that. Another definition, really early definition in the 1800s, was a rude unhinging of the machinery of life. And I know it's not as precise, but this really draws your mind towards how the body produces blood pressure. And I think that's really at the crux of resuscitation, is how does a body actually make a pressure to be able to perfuse cells and tissues. Now, we on London's Air Ambulance, we have consultants, but we also have registrars. We have a new registrar every month. A few of them are here. And usually we have about a month of bedding them into the service. And I ask all of them a question. And basically ask them, how does the body physically generate blood pressure needed to perfuse the tissues? And actually, I've been doing this now for a few years, and I think only one person's given me a proper answer. So I'm a surgeon. I'm far removed from what anesthetists and that do, so I understand that many of you will be much more up to date on this kind of stuff. But it is interesting that most clinicians actually aren't, it's not on the tip of their tongue as to how the body produces blood pressure. The answers aren't bad though. Many of them will bring up this equation. So we understand, it's to do with cardiac output and peripheral vascular resistance. And if you, increase the heart rate or increase the stroke volume with some fluid, you can improve the blood pressure. And if you increase vascular resistance, you could improve blood pressure. But that doesn't really explain how it's made. Some people mention, the heart. They say, well, the heart's a muscle, it's a pump. That makes the blood pressure. Quite right, but the problem with that is in the blue here, we see the pressures in the ventricle. And in systole, yes, it gets up to 120, but there's nothing in diastole. So if it was the heart that was actually pumping blood into your cells, they would only get oxygen and nutrients during systole, which is a small fraction of the cardiac cycle. But if we measure the blood pressure in red, there's still a pressure during diastole, and that's what's driving everything into the cells. But how does the body make that diastolic blood pressure? And so the question usually generates down to how do we generate diastolic blood pressure? This is obviously a problem for, well, not a problem, all animals, all organisms have to have a method of doing this. And actually it's a problem that's not uncommon just in daily life. For example, you live in a town on a nice lake. Switzerland's got some lovely towns along the banks of some nice lakes. And the problem is, how do you turn pulsatile flow into continuous flow? When you turn your tap on, you want continuous water to come out. But if you want to get it out the lake, you're going to have to use a pump, which will push it in a pulsatile flow. So how do you get that continuous flow at your tap level? So what you need to do is pump the water up high into a water reservoir, and then give it potential energy. And then when you turn your tap on, it's actually the potential energy that runs the water out your tap. So you use the pump to give the fluid potential energy, and then that potential energy is what gives you the continuous flow. And that concept is what happens inside the body. I'll explain a little bit more. So, excuse my drawings, but basically, here's your heart, and here's your elastic aorta. What happens in systole is your heart contracts, squeezes the stroke volume into the aorta. About half of the stroke volume leaves, but about half of the stroke volume stays and stretches the artery. So you store all that energy from the heartbeat as elastic potential energy. And then, when you're in diastole, that elastic artery starts recoiling, giving you some pressure, closing the aortic valve, so there's only one way out, so driving your blood out during diastole. So keeping the flow to the cells continuous throughout the cardiac cycle. We call this, there's many terms for it. What we're calling it is a pressure reservoir. So the elastic arteries, the major elastic arteries, so the thin-walled ones, they are storing the heart's energy and then providing that energy when the heart's not beating. Really, really important for coronary blood flow. Okay, the rest of the body could probably get by on pulsatile flow, but the heart only gets supplied during diastole. So if you don't have pressure during diastole, you won't be giving any oxygen to the heart. It's trying to create this. So then, how does this pressure reservoir fail? Two ways, really. One, you can have lost so much blood that you don't have enough stroke volume to distend the arteries. So they can't get any stretch, so then they can't push the blood through. The body is really, really good at compensating for blood loss. So we know from that equation I put up earlier, you can simply increase your heart rate. That will increase it. You increase your peripheral vascular resistance. It takes a bit of time, but you release a lot of adrenaline and you start vasoconstricting. You venoconstrict, so you push more blood into the system, so you increase your preload, and you can fluid shift some fluid from interstitial spaces into the bloodstream. So there's lots of compensatory mechanisms. So to get to a state where you don't have enough blood to fill the aorta takes a little bit of time usually. Okay, and that's why we say you need to, once you've lost about 40–50% of your blood volume, that's when you start getting into really profound levels of shock, because that's when you probably don't have enough blood anymore to distend your aorta. The other way you can cause this pressure reservoir to fail is by simply making a hole in the elastic artery. Okay, so the easiest way to understand it is a balloon. You can blow up a balloon and it will maintain all that pressure on there, but the minute there's any kind of hole in the balloon, it's impossible to blow it up. You can't stretch it because there's no resistance to, the air will just escape through the hole. So if you make a hole in a major large elastic artery, you suddenly lose any ability to compensate by increasing pressure, and you lose that ability of the vessel to recoil and squeeze blood through. So here's someone with a hole in an artery, and you can see your blood gets pushed through from the heart. Some of it's lost out the hole, some of it carries on, but the artery doesn't stretch. And then in diastole, you've got no recoil, so you're going to have no pressure in diastole. So we thought about this. This is all great in theory, and like I said, this isn't a theory we came up with. This is one of the very earliest understandings of how we produce blood pressure. But we wanted to see if we actually see patients with this, and if we can explain certain things that we see, because it doesn't always fit the very sick patients into the textbook descriptions of hemorrhagic shock. So we hypothesized, what would pressure reservoir failure actually look like? And these were the kind of things we thought we might see. So firstly, you get a very low diastolic blood pressure, okay? Secondly, you'd have a wide pulse pressure because your heart would still be able to generate the systolic, but it wouldn't be able to generate the diastolic. So you have this wide pulse pressure and all the clinical signs that go with that. Thirdly, you'd immediately have quite significant myocardial ischemia. So that heart almost instantly would not be getting any kind of oxygen delivered. So it would be ischemic, and you'd quite soon get cardiogenic shock. And then you'd see the systolic start dropping because the heart won't be strong enough to maintain a normal blood pressure, systolic pressure. And you'd probably die very quickly because there's only so long that a heart can beat without getting any oxygen supply before it would have to stop. And that would probably look like our hypoxic arrest, so degenerating to a bradycardia and then an asystole that wouldn't really be able to be resuscitated from. So then we went and had a look at all different streams of evidence within our service to see if we actually saw any patients that looked like this. And the first group we looked at, we see about 200 people a year. Even though we are very rapid response, we still get to about 200 people a year who are already in cardiac arrest when we arrive. So sometimes, less than 5 minutes, usually 10 to 15 minutes after their injury, and we get there and they already are dead. And we try and resuscitate them. But luckily for us, the ones that don't make it, they get examined by forensic pathologists, and so we know what happens. So we had a look at this group. And particularly, I was interested in the ones who've been stabbed, because penetrating injury is far more likely to make a hole in an artery, in an elastic artery. So we had a look at 50 consecutive cases that had been stabbed and then had died pre-hospital, and then had a forensic report on them. And what we found was this, interestingly. So of the 50, 28 had an injury to one of the major elastic arteries, so whether it be the aorta or one of its main branches, so any big thin-walled elastic artery. 20 of them, I think about 22, had a hole through the heart, and then 2 out of that whole 50 had any kind of other injury. One was an airway that was transected, so it wasn't even bleeding, and the other had a hole through the superior vena cava, so he bled venous blood. But really interesting that out of that group that we just picked, going, okay, someone who just rapidly dies within 5 or 10 minutes, we saw that actually more than half of them have a hole in an artery. So we thought, there is probably something here. We also looked at it penetrating and blunt, and it's just interesting that we didn't see that much of it on the blunt side. It was mainly brain injuries, and other is bleeding, but bleeding without a hole in an artery. You do, however, get major arterial injuries in blunt trauma, of course, aortic injuries, major pelvic injuries. So. Then we wanted to go and have a look at our hemodynamic data. So we collect, both from non-invasive and invasive blood pressure on a lot of our patients. This, however, was just a bunch of registrars with us, took all their blood pressures, averaged it out, and as you would expect, normal blood pressure, 120 over 80. And when you look at this, though, just keep an eye on it. So we're interested in the diastolic pressure and the pulse pressure. So the pulse pressure is the distance between the two. So diastolic pressure of around 80 and a pulse pressure that's about 1/3 of the whole distance. We then looked at a whole lot of people who had just been bleeding. So they had hemorrhagic shock, but we knew they didn't have a hole in an artery. I'll give you a few cases. So here again, this person, very shocked, blood pressure, 70, but still maintaining a decent diastolic, so his diastolic's above 50, very narrow pulse pressure, and that's what we understand by hemorrhagic shock, is the pulse pressure narrows. Obviously, these patients are getting treated, so you can see these effects of treatment as you go, but starting off, showing what we'd expect to see in hemorrhagic shock. Another patient, again, same thing, really shocked, systolic, what's this blood pressure? 55 over 40. So not, these patients look sick, but still got a decent diastolic, narrow pulse pressure. Another one, same thing again, really shocked, but same. And then we have the arterial cases. So these patients now are bleeding, but they also have a hole in a major artery. And what we find is, look how wide the pulse pressure now is. This is more than 50% of the whole distance, and really low diastolics now. That's down at, I don't know what that is, 35. Remembering that coronary perfusion really, once you're under 50, is really poor. Here's another case. Interesting here. So clearly the heart is still strong. So it's generating almost normal systolic, but can't generate any diastolic pressure here. It's really low there. And a lot of these patients are young, healthy, very healthy hearts. So we see that. And this case was really interesting because the clinician clearly described a collapsing pulse. Said, this patient looked awful. They looked like they were dying. They were pale. They were gasping. But when I felt their femoral pulse, it was bounding. Of course it would be bounding. You've got a massively wide pulse pressure. But they were confused by that. They was like, why would I feel that? We're expecting when that picture to not be able to feel any central pulses. Another one, again, look how low this is. This heart's not getting any oxygen, but the heart's still strong. Lastly, just another one, just same points, really low diastolic, sometimes maintaining their systolic. So a little bit of evidence that this might be going on. Then we went to have a look at cardiac biomarkers to see if we were actually getting cardiac ischemia. And the one we looked at was heart-type fatty acid binding protein. So if you're not familiar with it, look it up. It's much better than troponins for looking at ischemia. One, because it's released almost immediately, and only to ischemia. So ischemia of myocardium causes its release. And it's very sensitive and specific to the heart. So this was a colleague of mine, had done his PhD on cardiac issues in trauma, and he let me look at his data. So this is 300 patients prospectively collected, and what we did is we divided it up into patients who weren't shocked as a control, patients who were shocked just from bleeding but no arterial injury, and then those that had a major injury to an elastic artery. And these were the results. I'll talk you through them. So we took bloods as they arrived in the hospital, 1 day later and 3 days later. So the light gray here is people who weren't shocked. And as you can see, the normal is under this red line. So that generally, as you'd expect, non-shocked patients had no cardiac ischemia. Gray is shocked just from bleeding. So they did have some cardiac ischemia that quite rapidly recovered. And then the black is patients with a elastic artery injury, and you can see really significant, even compared to just normal shock, really huge increases in markers that the heart is ischemic. Then the last piece of evidence before I hand over to my colleagues on how we treat this, but is I'm sure the right criticism for this data that I'm presenting to you is it's very hard to tease apart pure blood loss from a hole in an artery, because you make a hole in an artery, you get a tremendous amount of blood loss as well. But what we did notice is this as well. So this is someone who we had an A-line in, and we recorded, and we have a lot of these when we did a Reboa. So over here you have the patient before intervention with this wide pulse pressure, low diastolic pressure. Yes, they've bled a lot, but they've also got a hole in an artery. And instantaneously, when you blow up the balloon proximal to where the hole is, you re-establish that pressure reservoir, because you take the hole out of the picture. So now when the heart pumps blood into the aorta, it can distend and can make a diastolic blood pressure, and we see it immediately. So as you blow the balloon up, you get diastolic pressure. Now you'll be giving your heart oxygen, and if your heart's oxygenated, then it will recover, and you get back to normal blood pressure. So that was the evidence that really showed us that actually, and this is so quick that it couldn't be related to the transfusion. They're clearly getting a blood transfusion at the same time, but it's so instantaneous that it's not related to how much blood you've given. So essentially, in conclusion, so my priorities, and I'm sure all of yours are in hemorrhage, is stop the bleeding, replace the volume that's lost, try and avoid coagulopathy. And I think that's a good 3 priorities. But I'd add this one for the super sick patient that I'm trying to describe to you, so the sickest hemorrhagic shocks, is try and re-establish functioning of that pressure reservoir so that you can establish adequate coronary perfusion, because otherwise you're dealing with hemorrhagic shock and cardiogenic shock at the same time. Thanks. Give you over to Robbie.
Right, thanks, Ian. And yeah, I'd just like to echo the thanks for having us here. It's a great conference and a wonderful place. So thank you very much for the opportunity to come and ski with you all and talk about what we've been thinking recently. So what I want to do is to follow on from Zane's description of this pathophysiological mechanism and try and relate it to first a real case, a patient, but really thinking about it from the interventional perspective. So how can we target specific interventional strategies at this type of pathophysiological problem? Because I think, and we think, the future of all this for the really big sick patients that are, as Zane described them, very shortly after injury, we probably have to think differently to just, transfusion and protocolized sort of strategies and time to definitive care, because there are a group of patients that, despite doing all that, in our own data set and internationally in other data sets, the time to death is very quick. So it's difficult to get this group of patients to definitive care in hospital. So therefore, developing these types of interventional strategies targeted at these pathophysiological problems is important, but it's difficult to know what to do in each individual patient. So I want to describe a case and try and bring out some of this physiology, and it'd be great to discuss it at the end to get your thoughts on it. So this is a real case from last year. So this was a young man who had been riding a motorcycle and hit a lamppost. The ambulance, the crew that attended him described him initially from a bystander being completely lifeless initially. So he looked dead, didn't move, appeared to be apneic, and then starts to become agitated and wakes up. And on arrival of the HEMS team, he has a weak central pulse. He's got a high respiratory rate. He's able to describe pain in his abdomen, radiating through to his back. He's talking, but he looks really pale, and he's moving all 4 limbs. And this description on the left here is I guess this is a clinical tool that we use and try and teach our registrars to try and pick patients who have exsanguinating hemorrhage. So a group of clinical signs. It's not validated, but it's something we try and sort of think about with these patients to try and distinguish patients with exsanguinating hemorrhage from other patients who are shocked. And you can see that this young man, 90 minutes after he's hit the lamppost, is very pale. He's sweaty. He's gasping for air. He doesn't seem to have any peripheral venous filling. He's hypotensive, he has a low nasal end tidal CO2, he's very tachycardic, and he's sort of agitated. He's not perfusing his brain properly. So the HEMS team arrive, and they think, based on the way he's hit the lamppost, he's likely to have he had a sort of blunt impact to his upper abdomen. So they're concerned he has, visceral injuries, hepatic, splenic lacerations, but they also are concerned that he's had a big deceleration. So whether he has a risk of an aortic injury as a result of that deceleration and energy transfer. So in summary, these are the interventions that the team provide. And we're going to go back and go through this in a bit more detail to focus on the physiology. But they put in a 9 French subclavian trauma line. He has a blood transfusion. He has arterial access, Reboa, partial Reboa. He's anesthetized, and other sort of standard hemorrhage-related therapies. And I think, lots of you were at the station yesterday are familiar with Reboa as an intervention. So but it's probably worth just recapping on, I guess, how we think about it at the moment, because I think that's changed recently. And it involves placing a balloon catheter in the aorta, percutaneously in our system. And, I always thought about this, and I think most people think about this as a hemorrhage control intervention. And yes, if you do that, you'll drop the blood pressure below the balloon and reduce the amount of blood loss that's ongoing. But really, I think the R in Reboa, the resuscitative aspect, is the real sort of benefit potentially in this group of patients, following on from what Zane said. By really restoring proximal blood pressure, so creating resistance for the heart to eject against, creating blood pressure during systole, which will produce some tissue perfusion, but transferring that energy to the thoracic aorta so that we have tissue perfusion, particularly myocardial perfusion in diastole. So the resuscitative aspect of Reboa is the important bit, I think, and we think. But obviously you can do that in another way. If you press on the aorta, you can achieve the same thing. So there's more than one way to do this. We're going to focus on Reboa in this particular case because that's what happened. But it's really addressing that pathophysiological problem, which is key. So this is the timeline of this case. So we're going to go through the physiological aspects, but it's probably useful, I think, to try and see how this happens sequentially so that when we go through the physiology, you can piece it together. So the 999 time is the origin of the call. So somebody's put a call into the emergency services about this chap. The HEMS team arrive roughly 20 minutes after that. Around 15 minutes later, they establish arterial access with a small 4 French sheath. So the patient's also had a venous line put in, a transfusion started. The patient's been moved away from the lamppost, and the team are packaging the patient. But then it's quite quickly changed to a bigger sheath. So the Reboa catheter goes through an 8 French sheath. So there's a plan to do Reboa. So that 4 French arterial monitoring line is very quickly changed for a bigger sheath that the procedure could happen through. As that's happening, the patient is anesthetized. So semi-concurrently, one team member is changing the arterial sheath. The rest of the team are pre-hospital anesthesia, so positive pressure ventilation in the context of pretty profound shock at this stage. Patient has Reboa, and 60 minutes post-injury, the patient leaves scene. Partial Reboa is established, and they arrive at hospital 86 minutes after the injury. So just have that in your mind as we talk through this. So I just want to orientate you to, sorry about the changes in volume, I'm not very adept at using a microphone, it would seem, but bear with me. Just to talk you through this slide. So this is a sort of screenshot from a playback mechanism. We use a Zoll monitor. So EFA is early femoral access, okay? So we've got some, for all the slides, I've got this sort of procedural information on the left. But if you look at so P2 here is the blood pressure from this, which is the femoral arterial blood pressure. You can see the non-invasive blood pressure is up here, so that's not reading, it's like nonsense. He's tachycardic, but that's the arterial blood pressure. But I put them on this side to make it a bit clearer. I'm sorry about the scale, it's 0 to 300, you can't change that, so it's quite hard to see. But this is his arterial blood pressure 37 minutes post-injury. And you can see he's already got a blood pressure of 55/25. And as Zane's already described, that blood pressure to me looks unusual. So normally with blood loss, vasoconstriction, low stroke volume, your pulse pressure should be narrow. And a diastolic blood pressure that sort of limits the pulse pressure, the diastolic blood pressure should be no more than 50% of the systolic value. So if the diastolic blood pressure is lower than that, it'd be classed a wide pulse pressure. So, this guy already has a wide pulse pressure, which is unusual given the fact that he's so hypotensive, presumably from blood loss. Yep, so now we're 42 minutes in, okay? So this number is 42 minutes post-injury, not arrival of the HEMS team, okay? And yeah, the non-invasive blood pressure, complete nonsense. It's actually been switched to the P1 transducer. So this is a double transducer set, standard Edwards double transducer set that you see in your hospitals. It's now changed to this P1 transducer. So it's the same blood pressure, just measured through a different channel. And so he's a young man, he's a young guy, presumably no ischemic heart disease, and he already has ST depression, so evidence of myocardial ischemia, 40 minutes post-injury. And this is despite now he's having blood products poured in through a 9 French venous line. So despite standard care, he's getting more hypotensive with myocardial ischemia on his ECG. So now, 43 minutes post-injury, still got this wide pulse pressure here. And his heart's, it's intermittently generating systolic blood pressure. He's got hyperdynamic heart despite the ischemia, but he's becoming dysrhythmic. And no non-invasive blood pressure. And his heart rate's actually starting to slow at this point. So we've got this young man who has pretty good evidence of myocardial ischemia. Obviously, he's hit a lamppost, so there is the possibility he has an underlying myocardial contusion that's contributing. But it's progressive, and it gets better with treatment. So I think it's probably related to myocardial hypoperfusion and ischemia. And it gets, progressively more dysrhythmic, and with this low diastolic blood pressure. So thinking of that pathophysiological mechanism that Zane's described, this is likely to be causing this myocardial ischemia. And again, his heart rate's all over the place. He's got bigeminy, and this polymorphic kind of rhythm. So he's now, this is persistent. It's getting no better with transfusion. The team are now about to upsize the sheath and intubate the patient. And this is good because there's concurrent activity. So obviously, we're spending time with a man who's profoundly unwell, who needs to be in a hospital, messing around doing all this stuff. So we're trying to do everything as quickly as we can. But as a result of this change of the arterial sheath, what's happened is that the intubation, positive pressure ventilation, is happening before REBOA has happened. So the plan is to do zone 1 REBOA, but it's not happened yet. And so he's now been anesthetized. So he's had a positive pressure ventilation established. And the sheath goes back in, and now his blood pressure is 29/15. His heart rate, he's profoundly tachycardic, ischemic. And he's sort of really peri-arrest at this point. And another interesting thing I think to note from this cohort of patients is now we have a blood pressure here which says it's 86/53. So the current arterial blood pressure is 29. So one of the features that we see repeatedly in this group of patients is non-invasive blood pressure is very, very inaccurate. You could be quite falsely reassured by that blood pressure in this context, but actually, he's peri-arrest at this point. So he's now had REBOA, so zone 1 REBOA, so there's a balloon being placed via the femoral artery in the thoracic aorta, so above his diaphragm. And we're now 4 minutes post zone 1, so this is now 57 minutes post-injury. And so the pressure here is the pressure above P1, and the pressure here is P2 below the balloon. So you can see even 4 minutes in, he's still profoundly hypotensive, and he's still got transfusion ongoing, but he's still taking a while to recover. And now we're 10 minutes in, and his blood pressure is 64 systolic. 40 minutes post REBOA, we have a blood pressure which we'd be happy with in this context. And I think, so he's having large volume blood transfusion. He's got a degree of hemorrhage control, which should be able to restore stroke volume. Yet we still have profound hypotension for 40 minutes, which has undoubtedly been made worse by the positive pressure ventilation initially. And that's almost, I think, in my mind, we can't be sure, it's due to a degree of cardiac dysfunction, systolic dysfunction, which with time, an improvement in his coronary perfusion has recovered. But I think it's, in this case, in contrast to some of the other cases, that also the positive pressure ventilation has really pushed things, to a worse point in terms of his hypotension due to the effects of preload in this case. So we've now, the team, they've got to a point where, they're pretty happy with what's going on, 40 minutes post zone 1, and they're sort of ready to leave scene. And this is one of Carl Zane's master's student, one of his graphs, and this is of this case, and I think it sort of brings the physiological interventional principles out quite nicely. So this is him when the arterial line goes in, hypotensive, wide pulse pressure, transfusion ongoing throughout this period, not getting any better. So his diastolic actually is getting slightly worse. Occasionally we get blips in his systolic blood pressure in response to transfusion, but we haven't really got, we've not improved. We haven't got a situation, that we're probably going to get this man to hospital alive. So here is the point where the sheath has been changed, and he's also had been anesthetized. So when the pressure is reconnected, he's profoundly hypotensive. And really peri-arrest at this point. Reboa happens here, and you can see, as Zane described earlier, that this diastolic blood pressure immediately jumps up. The systolic blood pressure does improve, but it takes quite a while to recover. But gradually we have this cardiac recovery and improvement in his hemodynamics. But the problem with all of this is, obviously now we've created a situation where we have resuscitated the heart to a degree, and we have this degree of recovery, but we've obviously made the lower half of the body, all the viscera, ischemic. So we've blown a balloon up, the pressure below the balloon is low, and that's not something that's going to translate into survivors if we just leave it in that condition. And the timescales of pre-hospital use of this type of intervention are challenging. This man's still got to get to hospital, he's still got to get through the emergency department, he's still got to get to an operating theatre, he's still be prepped and draped, he still has a surgeon who has to then find the point of hemorrhage and get hemostasis. So we need to establish perfusion again to the rest of the body to mitigate the ischemic effect. So this is something that we've been, I guess, challenged by and trying to come up with a solution for. And there are a number of ways to do this, but this is how we have tried to target reperfusion of the body using this concept of partial reboa. So this is a slide from a guy called Austin Johnson, who's an academic emergency physician currently based in Utah, and this is one of his large animal models, which really are procedure, which we're examining in the context of an observational study at the moment, is based on. So the graph shows is essentially a large animal model of exsanguinating hemorrhage who's had reboa. So the pressure, the distal pressure, is the pressure measured from, in this case, the femoral artery of a pig. Okay, and then we've got flow on the y-axis, which is measured with an aortic flow probe in this large animal model. And the key things to take from it are, when there's no flow, the pressure's never 0. So no flow, the pressure's sitting around 12, and it usually sits between 10 and 15 millimeters of mercury because of retrograde venous pressure, hydrostatic pressure, etc. But if you bring up the distal pressure by about 5 millimeters of mercury, you have a flow rate of about 250 mils per minute. If you bring it up by another 5, you have around 500 mils per minute of flow. So the significance of that is, we'd like to measure flow below the balloon, but we can't do that. But pressure in this model has a fairly linear relationship with flow. So we can use pressure measured below the balloon, usually in our case from the side arm of the femoral sheath, as a surrogate for flow. So that's what we've been doing in a study that we're running at the moment. And the idea is to try and achieve this. So this is again a large animal model, and is looking at the difference between a patient who's had zone 1 reboa, so above the diaphragm, zone 3 reboa, just above the aortic bifurcation, and then partial Reboa, this technique. And this is lactate on the y-axis and time on the x-axis. So you can see that around 60 minutes with complete Reboa in zone 1, you have this big increase in lactate. Whereas if you have the balloon below all the visceral arteries, or you allow some flow, you can really mitigate this ischemia reperfusion injury. So that's the rationale for this technique. And this is just an example of, I think, how we are managing to do this, but we're obviously still in the relatively early stages of studying it. So we're now back to that slide we had before. So 60 minutes, 7 minutes post-injury, 14 minutes post-zone 1. The distal mean arterial pressure is 15, okay? So that's the pressure measured, displayed here, which is measured from the side arm of the sheath, which is in the femoral artery. The other blood pressure is measured from the tip of the catheter. So we've got 2 blood pressures above and below. But the key thing to note is the distal mean pressure here, flat line, is 15. And you can see that up here. We've now got non-invasive blood pressure, which is working, interestingly. So we're now 18 minutes post-zone 1. And you can see now, and it's really, and I'm sorry this scale is 0 to 300. It's probably impossible to see here, but there is a slight degree of pulsatility in this distal trace. And the distal mean pressure has now come up to 25. So based on that animal model, on that data, we can assume that, perhaps we've got around 500 mils per minute of flow established here. And the team have established that by removing some of the balloon volume while en route to hospital, trying to target this increase in distal pressure and return of pulsatility. And now as we're en route to hospital now, this is actually increasing. So this is partly as a result of more volume being removed from the balloon. So now the distal mean pressure is 31. You can see the pulsatility here. But also because of cardiac recovery. So now we've arrived in the hospital, and you can see that the distal mean pressure is now 34. And that's without more volume being removed from the balloon. So essentially what we think is happening is that the heart recovers, we're still replacing preload, stroke volume and cardiac output are increasing, aortic capacitance increases, and the bigger pressure above the balloon effectively allows more partial flow to happen past the balloon. So this is being introduced both by reducing the balloon volume, but also by cardiac recovery and more blood pressure above the balloon. And this is, really the final slide of this case. So now 37 millimeters of mercury. The pressure above is pretty stable. So I think we can assume we've got a reasonable amount of partial flow past the balloon. So we've resuscitated the heart, and we're now reperfusing the balloon. And obviously from this point, this patient needs definitive hemorrhage control and deflation of the balloon completely. But this, I think, is an example of trying to use this type of intervention to target the pathophysiological problem that Zane highlighted earlier, to allow this type of patient to perhaps survive to definitive care and potentially beyond. And I think the easiest way to think about the reperfusion aspect is that really it's creating regional permissive hypotension. So permissive hypotension is broadly, the evidence base would suggest that if you've got uncontrolled hemorrhage, it's probably a bad thing to give that patient lots of crystalloid, inducing a coagulopathy and disrupting clot. But the problem with this that strategy with this kind of patient, we can not give him any crystalloids, but if you induce hypotension, well, this guy was already profoundly hypotensive, and if you think about that pathophysiological problem that we've highlighted, to achieve permissive hypotension, you by definition you're inducing pretty profound myocardial ischemia. So it's probably not a solution for this man. Perhaps if you've got microvascular bleeding or venous bleeding, and there's other examples Zane showed, you allow that patient to become hypotensive, you allow clot to form, chances are they'll recover and do fine. But probably not with this man. So really, perhaps Reboa and partial Reboa gives us the opportunity to both augment proximal perfusion, but then induce regional hypoperfusion around the region of injury. So trying to perhaps get the best of both worlds to a degree. The other thing that I think people raise quite rightly and struggle with is surely when you blow a balloon up in the aorta, you create high afterload, so you create more cardiac work, and you've already got an ischemic heart. You know, what's the point of doing that? But I think the key thing to think about is to get to get increased myocardial oxygen consumption, you have to have high wall tension, so you have to have hypertension. And in this example, and in most of our other cases, we haven't seen hypertension. And I think one of the reasons for that is because if you don't overinflate the balloon, so you've just occluded the aorta, as the heart recovers, you effectively distend the aorta and allow flow past the balloon. So you're sort of auto-regulating your afterload. So the more you eject blood and the blood pressure goes up, actually more blood escapes past the balloon. So you sort of mitigate, as long as you haven't over-distended the balloon, you mitigate the risk of inducing hypertension and therefore high wall tension and increased myocardial oxygen consumption. So you sort of, if you do it carefully, you can self-regulate and avoid that. And this, just to finish with this clinical example, this is a different patient, but another patient with zone 1 partial reboil, so pressure above the balloon, 107/63. Now a normal diastolic blood pressure below the balloon, pulsatility, a mean of 23. So I'm going to move on to the next slide. So nothing's happened to the amount of volume in the balloon between then and now, but just with transfusion and cardiac recovery, the blood pressure below the balloon is now 59, and we've got lots more pulsatility. So I think that's an example of this, self-regulating effect, that we can avoid high afterload and get more partial flow to reperfuse the rest of the body by this mechanism. So that's it really. I wanted to just highlight how perhaps in the future we can target this kind of interventional strategy at specific pathophysiological problems. But one of the key challenges is it's really hard to pick these patients apart. Patients who have blood loss, cardiogenic shock, neurocardiac response to injury, hypoxia causing hypotension and shock, trying to distinguish these different physiological problems to ensure we deliver the right interventions for our patients. And that's really the challenge. But I think if we can start to understand these pathophysiological problems like the one we've talked about and incorporate that with technology, artificial intelligence to provide decision support tools to make this kind of approach more generalizable, I think that's really the future. And also, this procedure is a bit of a faff. It's a bit complicated to do this in the pre-hospital setting. So we're trying to automate this type of care in terms of devices, I think will enable us to make it more generalizable. And then ultimately to test it in the context of research studies, out with places like London, which have quite a sort of unusual system in many regards. So that's the future. And we're running a study at the moment looking at this, and plan to develop that out in the future. So thank you for your time. I'm going to hand over to Rob now, who's our endovascular fellow, who's been working with us for some time to focus on some of the training aspects. But thank you.
Hello, everybody. Thank you for having us. Thanks for putting on an awesome week. It's great to meet lots of you over the last few days, and also to do it in such a fantastic environment as this. And to meet amazingly friendly and like-minded individuals is always a cool thing to do. So for those of you that haven't met, I look forward to meeting you later. But for those of you that have, it's been great. So my name is Rob. I am a London HEMS registrar, and I also work as the endovascular fellow half a day or one day a fortnight to try and bring some of this, what we've been talking about, to the fingertips of the clinical teams on the road, and also to our new members of staff, doctors and paramedics that rotate through our system on a regular basis. So that's what we're going to do. I've got absolutely no conflicts at all. With respect to last night, it was really lovely to meet some of you and see a little bit of a snapshot of what some of our training looks like. And over the next 20 minutes to half an hour, I'm going to take you through some of the challenges we have, and also some of the things that we've done to try and really nuance our training to make it as easy and as good as possible for our patients. So this was last night upstairs in the hotel. For those of you that enjoyed it, thank you. This was our mannequin that we're developing as a prototype to try and move not only towards training in the technical aspects of doing the procedure, but also to really push members of staff and clinicians in actually the decision making that underpins a lot of what we've been talking about, which is what we're going to talk about. This paper hasn't been put up yet, but if you don't know much about Roboa or you want to look at the most recent case series from London, there will be another one coming shortly, hopefully. This would be the paper to look at to sort of understand exactly the sort of patients that we see. With respect to the training, so we started Roboa a number of years prior to myself being involved, and there was a training package put together to try and bring people from varying backgrounds towards being able to deliver this patient to the very sickest patients. So these are the patients that aren't really getting to hospitals alive. So unless you work in the pre-hospital setting, you're not really meeting a lot of these patients. And we'll talk about a little bit what that was back then and what we've moved towards now. It's worth mentioning something called the PEER course in London, which is the pre-hospital emergency endovascular resuscitation course. And that is a course that we run both practically in a cadaver lab to understand the anatomy and the process and the procedure of what we're talking about from endovascular resuscitation, right through to actually doing simulations and understanding as teams how we operate to try and look after some of these patients. This is a copy of our SOP. So in London and lots of pre-hospital systems, we are underpinned by standard operating procedures, and that allows new members of our team to hang their hat on exactly what we're talking about and what we mean. And these are the 6 things that were in the original requirements to sign off for Roboa at the start. It's changed slightly, subtly, but not a huge amount, and we're going to talk about that going forward. It's worth saying that clinicians in our service come from varying backgrounds. So doctors, we have a surgeon like Zane, but most backgrounds are emergency medicine, anaesthetics, intensive care, and they come from a varying amount of background and experience from a doctor point of view with respect to looking after these patients, these exsanguinating patients on the road. A lot of people haven't got that experience before they come to us because it's incredibly hard to get in the patient cohort that we're talking about. And not just doctors. So our paramedics come to us from varying backgrounds, and they come from backgrounds across the London Ambulance Service in different specialist units within the ambulance service, but they come to us with a lot of desire to learn, but their learning needs might be different to our new doctors. So it's about understanding where clinicians have come from to try and take them forward to the next step. What we don't do, which is a few conversations I had with a few of you in the audience, is we don't try and see one, do one, and teach one. We really try and get people to have proper understanding and proper knowledge to be able to apply that to the patients in which they see. And actually we need to do that because we can't guarantee that our members of staff in their sign-off or training period, which is normally 4 to 6 months, are going to see one of these cases before they're doing it in real life. So it really is around the training and the simulation that we put them through. But like I said, everyone's journey to get to that point of being able to deliver endovascular resuscitation on the road is very different, okay? And there is a journey for all of us. I've been on one, these guys have been on one, and the people that are starting or started this week, they're starting the journey in a different place. But everyone is going on a pretty steep learning path, like we all do when we learn a new technical skill. But it's not just the skill, it's around having the right attitude, it's about having the knowledge, it's about downloading these people at the front to try and pull all that information into your brain so you can make some decent decisions at the time. But we all need different things to be able to do what our patients need. So I try and tailor the training that we do. So I deliver all the training to all the new registrars and paramedics, and I really sit down and try and understand who they are, where they've come from, and what they need to be able to get them to the end point. Because there's no point me sitting down with anaesthetists talking about cell dinger techniques, but with paramedics there is. There's no point me talking to people that know lots about anatomy, about the detailed anatomy of the aorta, but there is for some paramedics that don't know that and don't have that as part of their training. So I really try and tailor it to try and get everyone to the same point at the end. On the journey, there's some things that we'll pick up all the time. So we'll make sure that everyone has the right anatomy knowledge. And everyone comes to us a lot of the time thinking they know a lot of anatomy, and we try and really drill that, and we try and cement that to make sure that they do understand both surface anatomy, both anatomy of the truncal anatomy, and most importantly, the aorta and how it varies at different levels due to the size of the aorta, where the vessels come off. So we can really then start to hang your hat on building from the injuries you're seeing, the mechanism of injuries, right down to the vessels involved, so therefore we can target our interventions. But without that underpinning knowledge that is sometimes presumed, we don't always have that. So we do try and focus on that quite a bit. Identifying exsanguinating patient. Robbie or Zane, someone put up a slide of the not validated, but the hateful eight, some of the signs of what we look for. Hey, that's in the context of a mechanism of injury compatible with causing those sort of injuries, and it's got to be injuries that can cause exsanguinating hemorrhage, and also in an appropriate time frame. If you're seeing them a couple of hours after injury, they're probably not exsanguinating. And actually, it's about making sure that you're building up that whole picture of that patient. And the doctors and paramedics that come to us, a lot of them haven't seen patients bleed to death in front of them. And actually, we're talking about a patient cohort that even if you work in the biggest major trauma centres in London or the level 1 trauma centres equivalent, you're not seeing these patients regularly. These are a different patient cohort. And some of the endovascular interventions we're doing, we're delivering patients to hospital that hospitals are not used to looking after, and it's taking a time for the hospitals to catch up. So it is identifying those patients is a key bit of what we try and talk about within our training. It is not all about putting balloons into aortas, and in the training that we do try and emphasize that this is one intervention that goes along concurrently with lots of other gold standard care. So our routine for exsanguinating patients would be big wide bore access. If you can't get that in a peripheral vein, we would put in a 9 French cell-doing infraclavicular without ultrasound. And that is routine and standard, and we drill that and we do it safely. We also deliver pre-hospital blood products. We also make sure that patients are splinted, packaged, kept warm, and do all what we call the essential stuff. We do it right, and we do it right first time. That's really important, because without that stuff, and just focusing on endovascular, that's probably not the right thing to do. So we don't do this training in isolation. We do it as part of the whole patient package, which I think is quite important. Robbie touched on concurrent activity, and that's something that's really important, because we can see, if you do all these interventions, you can see how time can run away with yourself unless you're doing it all concurrently. And we do try and train. Normally we have a 3-person team in our team. So on our helicopters we've got a doctor, or 2 doctors, a consultant, a registrar and a paramedic, and we train to work concurrently. And when we have a 2-person team at night and a second 2-person team in the afternoon now, we sometimes, for these big jobs, might have 2 HEMS teams on one scene, trying to work concurrently for that patient to get them to the end point of definitive care. Balloons and aortas is not definitive care, but it is a stabilizer to hemorrhage control, resuscitate the heart, and get them, hopefully, to someone that can fix them. As part of our training, we obviously go through equipment familiarization. So a lot of people haven't played with ER catheter or Reboa catheters before. So we take them through every single step of the procedure, and we go through the basics of what every single bit of kit is, what size it is, what shape it is, how to use it, how to use an ultrasound, our technique for getting percutaneous access using ultrasound to make it as safe as possible and to make sure it's in the right place. So yeah, we do focus a little bit on the Reboa balloon itself, but there is a lot more about how we actually train and understand everything from the first initial percutaneous access right through to the decision making right at the end of that Reboa, right to the point at which you're going to inflate the balloon. And there's a lot of kit that we expect people to know inside out, and our bags, which I'll show you in a minute, are laid out in such a way that it sort of takes you step by step through a flap system that you can work from one end to the other, right from the setting up the transducer set at the start, right through to a troubleshooting guide at the back if you put the balloon up and the thing has happened that you thought would happen. So we've got everything laid out in an ergonomic way for our teams. One of the key things we teach is early femoral access. So we mentioned a little bit about 4 French, that would be our femoral access point, and that goes in our common femoral arteries. And we try and instill early femoral access to our teams, or to the teams that are working at London's Air Ambulance, as relatively routine practice for patients that are shocked and code red, that have injuries that we think are below the diaphragm, that might be amenable to endovascular resuscitation, a technique in the moving forward. Something to get something into the femoral artery as early as possible allows you then to upscale that to the 8 French that we need to put in a Reboa catheter if required. Maybe that you don't use it and you just use it for invasive blood pressure monitoring, which is fantastic, and it is also available for the teams for patients that might benefit from invasive blood pressure monitoring that don't necessarily fit a Reboa criteria and aren't necessarily bleeding. There are obviously other patients pre-hospitally that can benefit from invasive blood pressure monitoring. One of the things that people sometimes struggle with, or really take a bit of time over a cafetiere of coffee maybe, is just to drill and talk about decision making. And decision making in these patients is really key. all of us think we can get into a femoral artery until one of our colleagues described it as cannulating a pixel. Do you remember that? Because some of them are closed down so small. So all of us think we can do the procedure, but actually some of the decision making, especially when you're in the dark, in the rain, surrounded by firearms police officers, with people screaming down the road, all this sucks your bandwidth. So we need people to be really clear about how to make decisions and how to target their interventions to make sure we're delivering the right things to our patients, whether that be injured bluntly or penetrating. Decision making is really key, and it's something that we're working on with the new mannequin to try and really bring more decision making into the way that we train and simulate, which is cool. For a BOA, one of the key decisions is zone 1 and zone 3, and that comes down to right at the start of your job about how you've examined that patient. So when we go out to a patient, we walk at the most of us will do a top to toe with our eyes and do a lot of our primary survey with our eyes and work out how they're breathing, where their injuries are their legs splayed, have they got a pelvis, have they got open injuries. We'll work that out as we go to them, and then we'll do a proper primary survey before we declare what we think the injuries are. If we don't do that bit right at the start, and we then don't peel off and understand the mechanism and then come back and re-examine if we need to, it can make the nuancing of exactly what the patient is injured from or what the vessel is that we need to target a little bit difficult. So we really need to get those essential things right first time at the start. For us, if we do think they're bleeding below the diaphragm, if they're in the abdomen and they're in this exsanguinating state that we've described to you, then zone 1 would be our option. And zone 3, which is lower down the aorta, sits at the bifurcation of the aorta where it bifurcates into your common iliacs, would be for your disrupted pelvic injuries or fractures with vascular injury as well as bony, or your junctional sort of femoral injuries for vessels that are not amenable to tourniquets. In London, zone 3 are the sort of cyclists that are run over by lorries, which unfortunately aren't that infrequent, or our stabbing patients that are stabbed high up in the groin, and they can sometimes either not completely transect and it continues to bleed out, or they can transect and it can pull back from the elastic nature of the femoral, you can't get a tourniquet anywhere near it. So these are the sorts of patients that we see relatively regularly. Within our training, we obviously need to understand troubleshooting because not everything goes to plan. It might be that we've got something wrong with the procedure, it might be we have something wrong with the kit, or we might have had something wrong with our diagnosis that's led to this whole thing happening in the start. So we have a way that we try and train with respect to troubleshooting to make sure that everyone on the scene is on the same page and we troubleshoot quickly together. One of the things that we talk about a lot is pace. So we want to deliver our patients to definitive care as quickly as possible, but we want to deliver patients as quickly as possible that are resuscitated, that are amenable to further intervention, right? So we don't want to deliver someone that has had no diastolic and they're in cardiogenic shock and they're in a profound state. So actually, it's sometimes worth just investing a bit more time on scene to some of our patients to allow us to deliver them in a state that someone else can then take the baton on and give them a chance of survival. But pace is key. And we need people on our teams to work really quickly, and the training has a responsibility to do that, to make sure that we take people from the basics right through to when we sign them off, doing it quickly and really working pretty well together as a team. In our training, we all get things wrong in training, which is the whole point of simulation. You're in a safe space, right? But we also go around this sort of circle of failing, trying, getting better and better, and we lead to success in nearly all of our doctors and paramedics will get to that point by the time they sign off from an endovascular point of view. And sign off is a term we use for saying that they are independent to go forward and go and look after the people of London. We also learn things from our training and also from our patients, and these are some of the things that we've learned. These won't be a surprise to some of you, but we've learned that sometimes you can spend a long time doing these unless you have concurrent activity down to a fine art. There's some people that come to my training sessions that are really scared of doing these interventions. So it's about taking this really complex intervention and trying to persuade them over a period of time, maybe sometimes days or weeks, that they can do it and show them they can do it, and then try and remove that fear from them. So if they need to deliver the intervention, they can deliver it almost automated from a muscle memory point of view, so they can spend all of their bandwidth on decision making. There's also failing to get access. So sometimes we can't get access. So I've certainly been to a case with someone in the room actually of a patient stabbed in the buttock where they were in an agonal state when we arrived. They were bradying down and we were unable to get femoral access. There was no femoral artery and femoral vein visible. We spent a few minutes doing that, and then we had to bail. So everyone has to think about what the next option is, and the next option in our system is to do a thoracotomy, because the whole point is to get proximal aortic control, to stop the bleeding, and to resuscitate that heart. And that's what we did. So it's about making sure that we don't become task fixated in the groin when there are other options available to us if that's what the patient needs at that time. The peri-arrest patient, sometimes people can sometimes not know what to do, not the experienced consultants obviously, but sometimes the paramedics and the doctors don't know what order to do things in, so that can sometimes throw up some nice lessons in simulation. The other thing to say is that as a standard in the London air ambulance system is that penetrating trauma, we're quite open about wanting a really short scene time, right? So we want patients to hospital to where there is a surgeon that can fix the problem. And sometimes that puts a little dichotomy in your mind, because sometimes we're saying, actually, it might be better to stay for a few more minutes to get them to hospital in a better state so the surgeon can actually have a chance of doing what they need to do. So that can sometimes play in your mind, and that certainly led to some decent lessons in the simulations and training that we've done. One of the other things is that we do miss cases. So every system, we have a really robust governance system where we review every single case to make sure that we don't miss any patients and we haven't done a disservice to anyone. And if we feel like we have, then we really focus in on that and understand why that's happened and how we can relate that back to our training to try and prevent that happening again. All of this leads into what Robbie was talking about, making sure that people understand when and why we use Reboa and who we use it in, to make sure that we have hemorrhage control when we need it, but also as a tool to resuscitate the heart. And that is key, and that's the stuff that's changing as we speak almost. So when we get to doing all this, when we make sure that people are ready to practice independently, we want them to do something like this. So this is a picture off a website, because someone took a picture of us out of a window, so it's all over the internet, unfortunately, which is why I'm putting it up today. This is a Reboa scene in South London. You can't see the patient, thankfully, but this is simultaneous activity of people in the groin, of an APP managing, an advanced paramedic managing an airway, with the armed police officers putting their guns down and setting up the transducer sets for us, because when we arrived at this patient, they were agonal with a high femoral wound, and we had to act quickly. And in this case, we were able to get in just in time, and we were able to get a balloon up at an appropriate level, at an appropriate time, to get them to a hospital that looked after them. So we need to take people when they come to us, and we give them that tailored one-to-one session. We discuss loads of the cases that we've done to try and have that institutional memory and learning for our new members of staff. We have a set of seminal papers which we're going to touch on in a second, and then we moulage, or simulate to make sure people are happy. And that culminates in a sign-off process to make sure that we know that our doctors and paramedics are able to get on the aircraft and go and look after the next patient that's trying to die under a lorry. And that's really important for us to make sure that they feel ready to provide that intervention should it be required. These are the 4 seminal papers that we use. We call seminal papers because this gives the real background, context, history, to give people a real base layer for us to allow to build on in our training. And these are papers that we discuss regularly. And I think we'll add some more to this in the very near future, but these are the current ones that we get our new members of staff to read. So we have bags like this, like I say, and they're Reboa bags, and they say Reboa on the side, not because we like to show off about doing Reboa, it's because sometimes we ask someone that hasn't seen the back of our car to go and get the Reboa bag, and it's quite obvious which one to get. But on the right-hand side, you can see this is how we simulate. So we don't simulate in a warm environment. We don't simulate on the table, because all our patients are on the floor, and in the cold, and in the wet. So if it's raining when we're doing simulation, sort of tough shit. We're just going to get on with it because that's what our patients are going to need. But you can see the bag open here, and it's got different pages. And the pages take you through a step-by-step process to try and remove any angst at the moment of that, or that pinpoint time that you need to put in the needle to get your femoral access, which is the key part of the start of the intervention. And it allows you to go through step-by-step the bag, and it takes you through, or takes away that burden of information. And we really do simulate. So we simulate with mannequins, which isn't always great because we can't make it as human as possible, but it does allow us to cannulate the mannequin, and it allows us to put balloons up at different zones. And we even have waveforms on our monitors here from putting a Reboa catheter in. So this is an 8 French sheath in a simulated common femoral artery with the Reboa catheter in, monitoring on the Zoll that we use, the actual Zoll that we use, and we use exactly the same kit that you saw yesterday with a plastic tube, and we can simulate quite nicely with that. But it is all about practice, 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 and it's really, really key. Not just for our new staff, we obviously have quite a few doctors and paramedics that work with us on an ongoing basis, and for that we want to make sure that everyone's current and happy to deliver this intervention. There's no point having some staff that have been in the system a long time that aren't happy with the kit or the changes in the process and the new knowledge and research that's coming out that really helps make those nuanced decisions. So for our teams regularly, we do have monthly training sessions. I also teach quite a bit of anatomy, so I invite our paramedic group especially into the anatomy lab to get them hands-on with cadavers at the University QMUL, so allow them to understand what an aorta is and the direction of an external iliac artery and the fact that it deep dives into the pelvis. All those sort of things are really key for people to understand. The peer course, we recently ran a Pan-London endovascular symposium, which I think we'll do again. There's also the UK Reboa trial ongoing around the UK, which Robbie's key about, and actually that allows our teams to stay current within the setting they work in as well. It's an in-hospital trial, but it allows you to think about and to really think about the Reboa from a different point of view, and those are translatable skills that we see people taking from those training days as well. We also debrief every single endovascular case, both from a team perspective and also an equipment and decision-making perspective, to make sure that we can't make, or to see whether we can make it any easier for our future teams and patients, which is really important. And then we have a D&D process, which is a case review process in London, which stands for death and disability. But all of these patients would go through that process on a twice weekly basis to make sure that all the learning is then extracted from these case reviews and thrown back to the rest of the team that aren't at those jobs. So we have that shared learning constantly happening twice a week. In hospital, so it doesn't just stop with the roadside. We want to make sure that in hospital our teams know how to operate as a HEMS team when you step inside someone else's institution and what we do. We now have all 4 teams online, and this is King's with their plastic tubing, and this is how they simulate and train at King's College London in South East London, which is good. But we do simulations that are not only just on the street like this one is, but we take them right through the hospital. So we take these simulations and we'll take them into resus. We'll do that pit stop in resus for the essentials, which will always be a chest x-ray, pelvic x-ray, and blood gas, amongst other things if required. And then a decision about, are we going to CT or theatre? Nearly always we go to theatre. And then we stay with that patient and we simulate going right through to theatre. And we do that because actually our teams stay with these patients in most cases, not all, but most cases they stay with as the balloon operator right through until the balloon is deflated in theatre. So not only do we need to train them around how to put the balloon in, and not only do we need to know about how to look after the balloon and how to achieve partial Reboa and what to do if you don't have the response you wanted, we then also need to tell them how to, or not tell them, but have a discussion with them about how you transition from that really fast-paced trauma team leader into a more supportive role where you're supporting the hospital trauma team leader and you're just a Reboa operator at that point. And that can be an interesting thing. So we do take them to hospital, these simulations, and we do test the hospital system as well, which is good. And the key for me in that hospital phase is around keeping momentum. Sometimes you can have a little drop of momentum when you hit a resus bay because you're like, oh, we're there, great. It's now someone else's problem. But actually we need to keep that momentum. We've also seen that when we take patients into hospital, teams can be falsely reassured by relatively normal numbers because they don't appreciate what has necessarily happened the 30 or 45 minutes prior. And that's really key, and we have to be the patient's advocate at that point to make sure that everyone on the team gets that information about how sick this patient is. And with a zone 1 balloon up, it's exactly this, well, not exactly the same, but pretty much the same as having an open chest with someone holding their aorta, but you don't have that visual reference, so people don't always understand that. So there can be some false reassurance. And about that changing role from being a pre-hospital doctor paramedic team right through to changing to actually supporting the trauma team leader in a major trauma centre and actually nuancing that balloon management whilst also potentially supporting the decision making of the trauma team leader. And it's done really well most of the time, but it's something for our teams to think about. That is just us in a resus bay. So what is the near future? So what's going to happen? I actually think we're probably going to move away from interventional training. So we talk about Reboa training currently. I actually think we're going to move towards bleeding patient training or training looking after like sanguinating patients to make it more patient focused rather than interventional focused. And I think that would be a good thing to do. We ask people to predict the future quite a lot, which we've talked about, which is quite a difficult thing to do. And actually we ask doctors and paramedics to pick patients that we don't think are going to survive to hospital. And actually the work into decision support and helping clinicians make those decisions on scene is really key, with some of the work that's going on by these guys. The arterial shock and cardiac resuscitation, which we already talked about, and the constant automation of the process, and also the procedure that we've talked about. And as Robbie said, the future RCTs and manuscripts will write all this up. But I think there's a lot to change, or there can be a bit to change with our training, but I think we're doing a really, really good job. And I'm really looking forward to having a discussion about this in a minute. It's lovely to speak to you all and meet you. And I'm going to hand over to Frank, and Frank will introduce himself.
Thanks, Rob. I think I'm the final speaker. Thank you, everyone. I'm going to start by echoing my colleagues in terms of thank you so much for having us. It's been an absolute pleasure to be here, and especially the effort that's gone through to make this a face-to-face element to this conference has to be applauded. So thank you so much for having us all. My name is Frank. I'm the patient liaison nurse for the air ambulance in London. And I suppose I'm going to start by borrowing a quote from yesterday's talk from Leif Rogners, where he mentioned that his talk wasn't very cool. So this one is definitely not cool. You're not going to hear much about balloons, but I am going to tell you about rabbits. There we go. Bear with me, but I want to try and tie this into why it's so important to have some of this stuff tied into all you've just had just now. These patients are big sick, but they do require some of this stuff. So bear with me, and hopefully as we go along, you will try, it'll all come together. Disclaimer, I know nothing about prehospital care, absolutely nothing. You're the experts on that. The bit I do know about is how you can go from this, which is a 25-year-old young man, pedestrian versus car, scan as you can see, starting ICP of 64, bilateral decompressive craniotomies, GCS3 on scene, horrible, hypertonic saline, absolutely awful. 25-year-old who just graduated with a degree in law and then was coming into London to do a BSc, an MSc in law, but he got hit by the car. Until 5 years later, this was him this year celebrating his birthday in Paris. He's about to start his MSc, having gone through all of that. It happens, it does happen, it takes a heck of a long time, and it's extremely difficult. A little bit about this, how you lose a leg, pedestrian versus a car again, how you can go and lose your leg, and then through all the trials and tribulations that takes you through, and everything that you go through, you and your family can end up doing this, writing a book about that experience. It happens. Patients do incredible things, but it's extremely difficult, and it takes a heck of a long time. It's a bit like this. You remember this from last year, March. This thing apparently was sailing through the canal, and a gust of wind turned it sideways. That's exactly what the patients go through. Only for them, that thing is upside down. So they're going through the canal of life, not a care in the world. Everything in life is as sweet as it can be. And then something out of absolutely nowhere happens, and their world is turned upside down. Imagine seeing that thing upside down. Recovery is putting that thing back up and putting each one of those containers where they were before it went down. The impact is incredible. It's not just the patient. That's the ship up there blocking the canal. The impact of that one patient affects so many people you will not believe. Family, friends, work colleagues, even us as clinicians. The impact is incredible. And unfortunately, unlike the ship, their recovery isn't quick. This ship was unblocked, the canal was unblocked in 7 days. Why? Because it was blocking 10 billion worth of goods per day. That's why it was unblocked. Our patients are not worth 10 billion, so for them, that's not an option. 7 days is not an option. And often, the Suez Canal is definitely not an option for the patients. They start from Singapore, but they cannot go through the canal. They need to get to Rotterdam. But for them, that ship going upside down blocks that canal for them. They cannot take that route. They have to choose another route. And whichever route they choose is longer, is more treacherous, it is full of ups and downs, tears, laughter, all frustration, divorce, the lot. It's all thrown in there. They do get to Rotterdam, but my goodness, what they go through, you will not believe. And the part that we play, all of us as clinicians, we might think we play a big part in that journey. We might think we play a very big part in that journey, but actually, we don't, sorry to say. We play a very small part, a really important bit, a very important part. I will not deny that, but it's a very small part in the context of getting to Rotterdam. A very small part. Whichever journey the patient takes, it is a very small part. Who do we think plays the biggest part? This lot. People ask me what makes a difference. If you get hit by a bus, if you get shot, if you get stabbed, if you get hit by a train, and you do not have family, if you get cancer, anything, doesn't have to be trauma, and you do not have this, forget it. Forget it. Recovery is hard. If you do not have family, it is almost impossible. Almost impossible. These are the people who get that young man who I told you about at the very beginning. Those are the people who've got him to where he is, to the point where he's about to restart his MSc, having had an ICP of 64. His mum has done things that will make all of us here absolutely send a chill down all our spines. They are the tugboats. If you're gonna move that ship, if you're gonna stand a chance to move that ship, you need that family. You need that family. That ship will not go anywhere unless you have the tugboats. They are the tugboats. And we are in danger in medicine of doing this. We are very good at this. We tick boxes day in, day out. We are very good at, has TXA been given? Box ticked. How quickly? Very good. CT within how long? Has to be an hour. Box ticked. And we go through life treating these patients, ticking boxes. A bit like this folk. We are very good though. We can change tires. We change tires very quickly. These guys, those of you who watch Formula 1 will know these tires are changed these days in less than 2 seconds, 2.5 seconds. That car is back on the track. That's what we do. We are very good at changing tires. We are very good at doing the balloons. We're very good at giving the blood. Very good at giving the drugs. Very good at RSI or DSIs. But what we're lacking and what's missing a lot day in, day out is we forget to speak to the guy in the middle of that. We forget that this is not just a piece of, this is a human being. It's not just a broken leg. It is someone with a broken leg. It is not just a brain injury. It is someone with a brain injury. It's not just a spinal cord injury. It is someone with a spinal cord, with a name and a future with a spinal cord injury. And we often forget that. And so, for me, that's the most, when you ask what do patients want, patients don't care about your blood. They don't care about your RSI. They don't care about your TXA. They expect those things. What they want is this. Is in amongst all of that stuff, there needs to be a degree of compassion. A huge degree of compassion. These are human beings. And we really need, if we're going to be complete clinicians, we have to adopt some of this stuff. We really have to adopt it in our moulage, in our training, and on the roadside, by the roadside. Because these are equal, these are our brothers and sisters. This could be your brother, this could be your sister, this could be your mom. Treat them as you would want them to be treated. We're going to do a couple of cases, just 2 cases, just to go through and just tease out some of this stuff. And I'll let you read that. So I think someone mentioned this is very typical patient in London, run over by a lorry. Unfortunately, all of them are always awake, always alert, all GCS 15 with horrible, horrible, horrible pelvic and lower limb injuries. Horrible injuries. Very sick, big sick patients. If I asked you now, what do you want to do for her? What would you want to do for her? She's still trapped underneath. Leave her there? Who wants to do something? What do you want to do? Analgesia. You've hit the nail on the head, actually. I'll stop there. Because I was thinking someone was going to tell me all the lovely things, all the Gucci stuff. Yes. So you hear that? Someone was going to say drug her out. But what do you think she wants? What do you think she wants? Someone's got a hand raised over there. She does want comfort. Definitely. In your toolbox, and you guys have toolboxes that are absolutely full to the brim, in your toolbox of skills, technical and non-technical, whatever it is, please, 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 as the gentleman mentioned, there is only one thing she wants. There is only one thing your patients want. And there is absolutely no excuse for there to be an advanced trauma team on scene, or any team on scene, and have a patient in pain. Unforgivable. Absolutely unforgivable. So before you drag her out, and the thing with these patients is you will find they are always silent. Always silent. You will never approach this scene. Very rarely will you approach this scene and the first thing you'll hear is someone screaming. Very rarely. So if you're waiting for someone to scream, you will wait a long time. A very long time. These patients are in pain. They are in pain. Give them something. Which brings me to these people. These are the most scariest of patients you'll come to. Anybody who's GCS 15 is a very, very scary patient. Those who are unconscious, you just get on with it. Those who are awake should be the people who keep you awake and give you nightmares, because they're hyper. They're hypersensitive, they're hyper aware, they're hyper alert. I used to think, until I spoke to a few patients, oh, surely if your leg was amputated, you're not going to remember anything else. No, they remember absolutely everything. And the reason they do and how they explain it is because all of us sitting here are thinking about cheese in about 45 minutes. We're thinking about skiing tomorrow. We're thinking about a couple of talks tomorrow. Our mind is everywhere. Everywhere. Them, when they're lying under that bus, or under that train, or under that lorry, there is nothing going through their mind. Absolutely nothing. It is blank. And therefore, they see everything. They hear everything. They taste everything. And they feel everything. These patients all complain about a cold scoop. They have an amputated leg, but you put a cold scoop under them, and they will remember it. Because there's nothing else going through their mind. And this is counterproductive, because we just mentioned about how we train. And believe you me, this is a mannequin. We train with mannequins. And the thing with mannequins, they don't see, they don't hear, they don't taste, and they don't feel. And therefore, there's a danger that when we go on scene with these patients, we will assume those things are not happening. They can hear everything you're saying. Please be cautious of what you're saying or how you're saying. Speak to them. Don't speak around them. Speak to them. Tell them what you're about to do. Reassure them. Give them comfort, as someone said. Okay? Please, please, please. They can smell everything. The one thing they always remember is the smell of diesel or burning metal. That stuff stays with them for the rest of their lives. They hear sirens. They hear your radios all going and going and going. And people going, oh, it's life-threatening. Oh, they go Profuse. They hear all this stuff. They might not know what it is, but they hear it all and they store it in. It's got nothing else to think about. So please, 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 be very cautious when you're looking after these patients. Last case. Sadly, this is a pandemic in London. It's worse than COVID and getting worse every year. We're seeing many of these children, and they are children. Majority of them, 50% of them, are children. And what that means is, I don't know how it happens, but their parents are often on scene. Often on scene. Sadly, these are fatal injuries. This young man has unsurvivable injuries, but his mom is on scene. Who wants to go and speak to her? There is no SOP for this. Nobody ever trains. Everyone trains around the thoracotomy. All of you, I can blindfold you all, and you will do the thoracotomy blindfolded. But nobody ever goes, okay, that's finished. Who's around? And therefore, the easy thing to do is to walk away and go, we've done our bit, let someone else deal with that. I say to these guys, if you're man enough to come and cut someone's chest, you're man enough to go and speak to the mom. But it's not easy. It is very, very difficult. It is far more difficult than putting that balloon in. It is far more difficult than doing the thoracotomy. But we don't mulage this. We don't talk about it. When we do D&D, when we brief, nobody says, what did you say to mom? What did you say to her? How did you say it? What have you, who else is in the room who's ever done this? What did you say? How did you say it? And learn from each other. Because there's no one size fits all. And if you don't think about it, if you don't reflect on how you're going to do this, the easy thing will be to walk away. And you will walk away. And there's people in this room who would rather not. And I know there's people in our team who would rather not go and speak to mom. And that's probably our fault because we haven't given them the tools to be able to do that. We've told them how to do the technical stuff, but we haven't given them the tools to do what is probably the most important thing. And often, they want to see their child. They want to see their child. This is a 14-year-old or a 15-year-old. Mom wants to see them. Now, that's a different level. This is where you wish you'd walked away. Because this, if you thought it was going to get difficult, it gets even more difficult. This stuff is really important. Really important. Why? Because sadly, and my colleagues here will jump at me, thoracotomies, majority of our patients die. There's a good percentage who survive, and I'm not saying don't do the procedure. Do the procedure because there's people who survive. And actually do the procedure because even the ones who die, the family are very grateful that people tried. People did their best. So it's important you do it. But on a whole, the technical aspect, the medicine around it, doesn't tend to work. So then the million-dollar question is, what are you guys going to scene? Why are you on scene? What are you delivering? What are you bringing? Because the medicine doesn't work. What is it that you're bringing to the scene? We need to think differently with this. And I think this is one of the most important things that you're bringing to the scene. That ability to go and speak to the mom and bring the mom to the side of their son and let them hold their hand and hold their head as soon as possible before you pronounce them dead, that is valuable, invaluable. Absolutely invaluable. That mom, that dad will never forget that. And that actually makes what is an awful. We go to so many of this and the outcome is the same. They're dying. You do this stuff and it brings something back to why we go to these jobs. Because after you've done 2, 3, 4, it starts to grain on you. But doing something different is really important because this is what happens if you leave without speaking to mom or mom seeing their child. That tent goes up and will be up for at least 24 hours while forensics are doing their bit. How long do you think it takes from the child being pronounced dead to the mom seeing the child again? In London anyway. It might be quicker here. How long do you think from the time the child is pronounced dead to the mom being able to see that child again? I've known it to be 6 months. Minimum 3 months, 3 weeks. And by the time the mom sees that child again, it's not their child anymore. So the stuff that you do at the scene is unbelievably important because she can at least hold the hand while it's warm. We had a mom the other day who soaked her scarf. She took her scarf out and soaked it in her son's blood and took it away with her. There's a point where the pendulum swings. The pendulum often is always swings towards the patient. You guys have to do everything you can to try and save the patient. But there's a point where there's nothing more you can do. And once you get to that point, the pendulum needs to swing the other way. And it now becomes not about the patient, it is now about the people who are left behind. And the things you do or don't do will have a huge impact on the people who are left behind. I hope I've convinced you that there's a place for rabbits, but you don't have to do it. The good thing with rabbits, you don't have to. You can walk away. You don't have to do it. But I would say, please think about it. And in your toolbox, of all the things you have in that toolbox, please, 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 let there be a little bit of compassion in there. Thank you.
Wow. Thanks, Frank. Thanks, Robbie. Thanks, Zane. Thanks, Rob. And thanks to all of you guys. They're very tough acts to follow for me. So it's kind of hard to know where to start. But thankfully, I'm going to just lean very heavily on their talks. I'm the last thing between you and your fondue, so don't panic, man. We're going to be done soon. But there's so much in there, and there's loads of all of that stuff from all four of these people. I have been told and reminded again and again, and we've talked about it in the pub, and we've talked about it on the helipad, and we've talked about it in D&D, and I learn every time I hear it. So I'm hoping there's some stuff in there that is maybe new to you, or is shines a new light on stuff. So we're going to go back through the case I started with, which might seem like a long time ago now. We're going to go back through that case and just pick out some little bits, and I want to hear from you guys. I know you've all been sitting listening, and I know you're tired and hungry, but please get stuck in and tell us what you think. So to start with, having heard from all of this lot, we walked through that case quickly in real time, right? And I want to come back to Robbie. Look at him there, very healthy. That was before his injury. Before his injury, man. Huh? That's the best photo I could find of you, dude. Yeah, there's no better photos, man. They look terrible. They all look terrible. But look, and it's better because largely covered. I'm joking, man. He's very handsome guy. But look, this handsome, lovely, healthy man, before his injury, blissfully unaware. But you remember his injury, right? Remember everything we said about his injury and his physiology. How many of you were worried about him? That's a ridiculous question. It's a very broad, nebulous question. But honestly, you know when you talk to people and you say, look, I've seen big sick patients, and I know when someone's really big sick and when they're not, right? And I know you've heard about loads of really mega physiology, and we've talked about patients that are dying and patients that have died. But really, when you're listening to that and you put yourself in that image of picking him up off the hill and what his blood pressure did, and you take him to hospital, how many of you were really, really worried about him? Leave your hand down if you're like, yeah, he's pretty sick, but I've dealt with that before, he's all right. Put your hand up if you're really worried about him. High, put your hands up high. Come on, what's wrong with your elbows, man? Are you really tired from skiing? Yeah, good. Okay, so that kind of looks like about 50% of the room, which is interesting. That's good, right? So about 50% of the room were worried about him. I knew he was going to be okay. He's hardcore. Okay, so we're going to pick into that in a bit. How many of you are worried about him? Thanks, man. Why? I know why you're worried. You're worried for different reasons. Come on, is nobody worried about? Look, screaming in pain. Thanks, dude. I was screaming in pain. What about the bunny rabbits? No one wants to give me a bunny rabbit? Pain relief. Come on. Disappointed. I think it's because how many of you here ski? Hands up if you ski. Hands up if you snowboard. Oh, you see there? It might be a coincidence. It might be a coincidence. All right. But I'll forgive you. I'll forgive you. It's not because it's a skier versus a snowboarder. It's because there were subtle signs, right? We all get that. There were subtle signs in the injury, the mechanism, the physiology, the behaviour. And I'll come clean and tell you that it wasn't a skier versus a snowboarder. That case, it was a real case. Sadly, it was another one. The case Frank just mentioned was a case I dealt with, a 15-year-old. I think that kid was before this kid. And it was emotionally scarring. It was horrific, speaking to mum and having to cover the chest with a blanket so that she could hug him, and then having to speak to dad, who then turned up afterwards. It was horrific. And it scars you, and it leaves you even more worried than you should be when you're dealing with a sick patient. But But anyway, sorry, I'm waffling on. The kid, it was a child. It was a 14-year-old child, stabbed right here, over the spleen. And you look at it and you think, that looks like it's hit the spleen. But he had all the physiological signs that I've mentioned to you. So forget the snowboarding and skiing bit. His lips were pale. Obviously his wrist wasn't deformed, but his lips were pale. And he wasn't, like Frank said, he wasn't screaming. He was quiet, he was still, and the first thing I noticed was his lips were pale. But this wasn't tenderness, this was a tiny little stab wound. He had a radial pulse. That was his heart rate, around about 95. The blood pressure on the screen when we got there, and he was loaded in an ambulance already, and that was his blood pressure. So, what does that mean? We'll come back to that. I mean, okay, let's go on to the next slide. At this point, no, let's go back. At this point, I want to ask you, let's all say, can you all raise your hands? Do you remember I asked you to think about what you wanted to do? We went through the whole case, what you want to do with him. Number one, we've already gone through who was worried and who wasn't, about 50% of the room. Can you all think about what you thought was wrong with him and what you wanted to do with him? And put your hands up, let me get this right, put your hands up if you haven't changed your mind on what was wrong with him. It's a weird question. Okay, we've got one taker. How many else? Another one? Hands up higher. So okay, 1, 2, 3, 4, 5. It's about like maybe 10 of you. You think at the start you knew what was wrong with him, and you're still convinced you knew what was wrong with him, yeah? Okay, cool. So do the rest of you think does that mean that everyone else in the room, so I guess, okay, I know. This is stabbing, yeah. Yeah, it's not you. Chill out, it's not you. But but he's as sick as you. He was sicker. So, but everyone, what does that mean? Does that mean we all think he'd injured his spleen and we knew what to do about it? Is that what you mean? Can someone who put their hands up tell me if that's what you meant? He'd injured his spleen and he was bleeding from his spleen. Is that? I tell you what, someone who put their hand up, tell me what you mean by that. You haven't changed your mind in what you think was wrong with him. Who put their hand up? Go on, tell me what you mean by that. Yeah, okay, cool. So you felt he was exsanguinating and you still feel he was exsanguinating. Okay, cool. Anyone else who put their hand up who didn't change their mind? Is that what you mean? Yeah. So it could be lots of things, is what you're saying? Yeah, okay. So hands up then, if you have changed your mind on what was wrong with him. There must be some hands, because there was only 10 for the last one. Okay, so come on, someone who's put their hand up. Not you yet, Jake, because he's already promised to give me some complicated questions. I'm not gonna pick him yet. Right, who else has changed their mind? Hand up, who's changed your mind on what's wrong with him? Tell me why. Come on, man, tell me something. Otherwise, fondue's going to take ages. I'm going to carry on with this until you're not going to get your fondue until you start talking. Who's changed their mind on what was wrong with this patient? No one. So why didn't you all put your hands up to the last one? Am I asking these questions right? Go on then, Jake. Have you changed your mind? Yeah, okay. So in case you can't hear, Jake is saying, look at his diastolic pressure. Now, this is non-invasive, and we'll come on to the screens with the monitoring in a minute. But you're talking about his diastolic pressure. Now, what do you mean? What do you mean by that? Yeah. Yeah, okay. So Jake is saying he now thinks, actually, rather than just exsanguinating, maybe there's a little bit more going on. And I don't know. I'm still learning from all of this as well. And this was the case where the penny dropped for me. This was the case where these guys have been talking to me about this for ages, going on and on and on about it, right? Like all the time. But it's interesting, and I find it interesting, and you kind of can't quite believe it because you're like, yeah, that sounds, I get it, makes sense, that's interesting. Why have I not seen that before? I've been doing this job for 10 years. I've been flying on the air ambulance in London for 10 years, and I've seen probably quite a lot of trauma, and I think, well, have I not noticed that before? There's a number of reasons. Probably haven't noticed it because we haven't talked about it, and we haven't made ourselves think in a different way. But also, we have done some different things. So since we've started the Reboa, launched the procedure of Reboa, we've started using femoral arterial access. So we're measuring invasive blood pressure monitoring. We're getting much more accurate blood pressure numbers, and we're recording it. And Robbie scrutinises all this data, and he can put trends together. And him and Zane will come to us and say, look, we're seeing a trend, we're studying it. But also with your individual patient, I mean, look at the difference in the numbers. Hang on, let's go to the next slide. I've got, this says 85 over 45, which to me still is, that's not a narrow pulse pressure, is it? That's not what you're taught about exsanguination, young person, full of adrenaline. A 14-year-old kid, the pediatric surgeons would tell me kids compensate really well. They vasoconstrict intensely, and they should have a narrow pulse pressure. That's not narrow. On top of that, look at this non-invasive blood pressure. That's really wide pulse pressure, but it's probably not accurate. It's non-invasive. Huh? That's the arterial one, is it? Oh, yeah, it is. You're right. Right, so even more impressive. Yes, that's why I took this picture. Thanks. See, this is why I need these guys, right? I'm like the normal one that forgets stuff. They're the clever ones. So well done. So that is non-invasive. And that is invasive. Now, I was super worried about this kid, right? I was absolutely crapping myself. And I'd just recently lost a kid after a kid after a kid, and I took the family, and I don't want to have to do that again. I'm really worried about him. But I was so interested, because the penny suddenly dropped with this kid. I was so interested, I actually took a picture of his monitor whilst he was nearly dying, which you may say is ridiculous, and you may say is unethical. I didn't take a picture of the child, and it didn't impact on his care at all. And you'll be glad to know I didn't send it or tweet it during while we were looking after him. But I couldn't resist. I was like, oh my God, it's happening right in front of me. And what was happening was, look at his pulse pressure. It's ginormous, and it doesn't make any sense at all. And what was happening to him is it was gradually widening and widening and widening until he suddenly deteriorated. His heart couldn't handle it anymore. It was happening right in front of my eyes. And let's dig into it a little bit more. What does this mean to you? Getting a bit restless. Does that mean anything to anyone? Yeah, hands up who's worried about a patient that gets restless. Good. Thanks God. Okay. And and again, it's a hard thing to describe, isn't it? But he was restless in an odd sort of way. You can reassure him, you can calm him down. And his restlessness was a marker of his shock as well, and that changed. He would calm down when you improved his shock state, even though the numbers weren't really making sense, but you could monitor how bad he was by how restless he got. It was interesting. What about this? His blood pressure drops to 90 once, only once, drops to 90, and then we gave him a bit of blood. We carry blood and either whole blood or blood and FFP, or nearly whole blood. We gave him, I think, like 1 or 2 units, and his blood pressure picked right up. Not the numbers you see here, but his blood pressure picked up. That's all right, isn't it? Who would call him a responder? He's a responder to blood. Hands up if he's a responder to blood. Cool. Hands up who would give him blood, actually. He's got blood pressure of 90. What does all the stuff about permissive hypotension tell you? He's talking to me. Says I'm thirsty. Says am I going to be all right? He's with it. He's aware of what's going on, and his blood pressure is 90 over 40. Should we give him blood? Isn't that like against the rules of permissive hypotension? Okay, we have to do hands the whole night. Hands up who thinks you shouldn't give him blood, because permissive hypotension and everything we know about it, this is only 20 minutes after his injury, dictates a systolic of over 80, maybe even 60 in penetrating trauma, is okay, or a patient that is awake and talking is okay. And you shouldn't give them volume, because you might increase the pressure, cause a coagulopathy, worsen the bleeding. Remember all the papers and the stuff about that? Does everyone ignore that now, or do we still stick to that? What do you guys do? Hands up who wouldn't give him blood because of permissive hypotension. It's okay, we're all safe here. You can say whatever you want. There's a few like half hands going up. Why are you scared to put your hands up? Yeah. Look, now we said at the start of the talk, you know, that we know that everyone's got loads of experience in the room. I don't want to like condescend you at all. I want to glean some of your knowledge actually. So if you, it sounds like you're all saying, no, forget permissive hypertension. I want to give him blood. Why? You're saying you'd give him some slowly. Why? Yeah. Yeah, so you're saying looking at him, you're making your own judgment that he's bleeding, and I want to keep up with that, but I don't want to up his pressure too much to disrupt a clot. Okay. Anyone else who wants to give him blood want to tell me why they want to give him blood? Because it kind of goes against what a lot of guidelines say. Go on. Yeah, okay, so you're saying you're making a judgment anatomically. I think he's bleeding from an artery, and therefore I don't really believe that a blood pressure of 80 or 60 or something is going to stop him bleeding. I think he's going to carry on bleeding anyway. Yeah, and you don't believe that he's going to form a clot. Is that different for you if the pelvis is crushed, or if, I don't know, there's a different sort of pattern of injury? Is that what you're saying? Yeah, it's hard to judge, isn't it? But you're saying you're trying to, so we're trying to hone in it more than what we would have done maybe 10 years ago with less experience. We're trying to decide, which is very hard to do. Rob was talking about anatomically diagnosing what's going on with your patient. Really hard to do. But you do have to think about it, because I think what you're all saying is completely right, and it's lovely. You've all got clearly a lot of experience in trauma, and you're saying, well, I believe that for some patients who I think have got a venous bleed, or they've got bleeding into their thighs from pelvic fractures or crush injuries, but I don't believe it if you've been stabbed in the spleen. I don't believe it if you've torn your liver in half, or I don't believe it, you know, there's certain mechanisms where you don't believe in what the guidelines are saying. And it's about the look of your patient, isn't it? And he was pale, and he was getting restless, and he's got massive pulse pressure. Okay, I'm not really sure if I've changed your mind on that, but it sounds like you were already on board with that. And the reason I gave him blood was because, yeah, he just worried me. I looked at him and I thought, I think you've hit your spleen. You look awful, and it's only been 15 minutes since your stabbing, and I'm really worried about you. So I'm actually not going to let you go in the ambulance. I'm going to stop and do a couple of things before we go. We'll come back to that. Okay, what else is there to talk about? How long have I got? I've got loads, got ages now, so get ready with your hands. So let's come back to this thing about responding. He drops his pressure, we give him a couple of units, his blood pressure improves, and a lot of you in the room agreed he's a responder to blood. Responders to blood do all right, don't they? Most of the stuff you read about really bad things are like, you know, people that are non-responders to blood. And actually, if you look at some guidelines that try and describe when you should put in a balloon, or when you should do a thoracotomy, or when you should do a laparotomy, and this is not in any way criticising those guidelines, because it's I find it very hard to describe to our team when we should do this very risky procedure, which is fiddly and time consuming and distracts you from what you actually need to do, is get the hell to hospital. It seems counterintuitive. He's the sickest person you're ever going to see, and we're telling you to stop and get the ultrasound out and start fiddling around. It's ridiculous. You should be running to hospital with him. And he's a responder. Where was I going with that? I was going to ask you if you think responders to blood are okay. Hands up who thinks he's okay because he's a responder to blood. Yeah. Yeah, and we talk about transient response, don't we? And again, it's hard to describe. But of any, I suppose what I'm getting at is when you saw those numbers at the beginning and you thought, look, his pressure's all right, you gave him a couple of units of blood, what's the big deal? He's okay, just take him to a major trauma centre. How many of these have you seen? You know, you've bust your spleen, you're going to be all right, you have a bit of blood, you have a CT scan, you go for surgery, you might go for IR, you might not even need operation, you get some blood and you improve. Yes. Yeah. Yeah, so we've got a question about whether you're worried about other pathologies. Yes, and it's really hard to work out. Yes, I was worried he could have a tamponade. I was worried he could have a pneumothorax or a hemothorax. Mostly for me, my biggest concern was it hemothorax? We now carry ultrasound. You can have a whole nother debate about whether ultrasound helps. I think it does, but I think you've got to be careful how you use it. I can't remember if don't think I scanned him. I think it might have been before we had our full ultrasound machine. But one way is to scan him and check if it's a tamponade or hemothorax, or he's fast positive. Another way is clinical signs. And I like looking at... I spent years being taught not to look at JVPs because it's inaccurate. And now I look at them again because I really want to know if it's a tamponade. And sometimes I find them very helpful. If the JVP is up in someone like him, my whole thought process is completely changed. And I'm preparing for a thoracotomy, and I'm running to hospital, but I'm getting everything ready, and my thoughts are a bit different. But yeah, he didn't have a raised JVP. His air entry seemed completely fine, even though he looked breathless. He looked acidotic. You know, patients with DKA, ketoacidosis, he looked like that. Have you seen that? You must have seen that. Lots of people nodding their heads. People that acidotic, deep, rapid breathing. But his chest seems fine. Doesn't seem injured clinically, but he's breathing deeply. Anyway, I don't really know if I've changed your thoughts on transient response or not, but what I'm getting at is that the physiology, to me, now wasn't as simple as it was before people like Zane and Robbie and Rob and Frank had talked to me about what they've seen. And it wasn't just about his blood pressure, and it wasn't just about where he's been injured. It was about a bit more than that. It was about this broadening pulse pressure. And as we travelled into hospital, what he did was, repeatedly, his pulse pressure got wider and wider and wider, and his heart rate went from 90 or 100 or something like that. And as soon as it hit almost like a critical widening, he dropped his heart rate. And he suddenly rolled his eyes back, and he looked awful, and he looked like he was going to die. And then we did some resuscitative measures, which I'll come on to in a minute, and he would improve. I mean, actually what we did in him was we gave him blood. I strongly believe in Reboa as a procedure for someone like this. Why didn't I put a balloon in him? I didn't actually put a balloon in him. The reason is because he was a small child. He was 14, but he was small for his age. We were told he was 12 when we first got there. And I usually teach our teams our equipment. There's a little bit of controversy with Reboa in children for various reasons, but particularly the equipment that we carry is the right size for an adult. And I teach our teams that anyone who's my size or above can count as an adult, and he was even smaller than me. If you can see it, we can't see it at the back, I'm quite small. But he was even smaller than me, and I was like, oh man, he looks, if this was an adult, I would definitely just put an 8 French in. No, I would do what I did, which is I started with a 4 French, even though in my mind I was kind of not sure if I'll fit a balloon in him because he's so small. I still couldn't resist putting in a 4 French, which is the smaller arterial line. It's less harmful. It allowed me to monitor his pressure. And it just gave me a few minutes to think, look, will I fit it in him or not? If he arrests, will I do it? I don't know. It doesn't matter now. Let's just put in a 4 French art line. Let's just give him blood. Let's go to hospital. In the end, I didn't put a balloon in. And I think in retrospect, probably lucky. I got away with it. I could have probably fit the balloon in. And the reason I think I'm lucky is because I ended up upscaling to an 8 French, which is probably more the problem than the balloon. The 8 French is quite big in the blood the femoral artery of a child that size. It will block it. It will cause clot. It could damage the vessel. But I did it because I absolutely crapped myself, and I thought, you're going to die right now in front of me. I've got no other choice, and I have to go against everything I've trained everyone else to do, and I'm going to put a balloon in you. And I ended up not doing it because we got just got away with it, with squeezing as much blood as we had. I think we had 3 boxes with us that day, either 2 or 3, and that's 8 or 12 units of blood. And we squeezed it all into him on the way to hospital, and he transiently responded every time. And he would sit up and talk, and his colour would improve, and he got better. But then he would deteriorate again. And for me, the key here was watching his pulse pressure cause, I think, cardiac dysfunction, poor coronary perfusion, and a bradycardia that was pre-arrest. And I tell you what, you didn't have much time to act. When it happened, what was interesting, if you're looking at the systolics or the non-invasives, I think you can be falsely reassured and say, well, actually, he's doing okay. He's transiently responding. We're going to make it. But what happened was rapid. Suddenly rolled back, heart rate dropped. He's going to die. And then you squeeze as hard as you can, and you just about save him, and then it rapidly deteriorates again. And I honestly think this case should have had a balloon in retrospect. And there have been case reports. It's a little bit controversial, but there have been case reports of this size balloon being used in children even younger than this. That's a talk for another day. He needs, my point is he needs very aggressive resuscitative measures, and this is the physiology that we're clocking that responds well to aortic occlusion. We don't need to talk about all these signs, but I don't know, is there any interest in any of that? I'm thirsty, we all know about that, but that worries all of us. Pulling his mask off, and I can't breathe. Have you guys seen that? Hands up who's seen someone bleed to death, who says, I can't, yeah, okay, hands up who's seen someone bleed to death, to start with. Cool, hands, love it. Hands up who feels like they haven't ever seen someone bleed to death. It's fine if you haven't, because actually it's quite rare. 1, 2. People probably feel like they don't want to put their hands up because you might be not as good a clinician. That's not true. It's very, very rare to truly see someone in that moment when they've not either died already or they are actually okay. So thanks for putting your hands up. I think there might be even a few more in the room. I don't know. But anyway, okay, the ones that have seen someone bleed to death, have you seen them say this thing, I can't breathe, I can't breathe, I can't breathe? Have you seen that? It's weird. It confuses you and you start to think, oh God, is it a tension pneumothorax? Or is it something else? What am I missing? They say that because they know, their body knows that they are not getting the oxygen delivered. So going back from the mechanics to the tissue level, I'm not clever enough to explain it, but their body knows they're not getting enough oxygen. And they put their respiratory rate up and they feel this sense of breathlessness as though they've just run a marathon. They can't breathe, they can't keep up with things. That's a worrying sign. So, we've kind of done some of this already, but I just want to pick out anything else that anyone wants to volunteer. You don't have to put your hands up, but please shout out and tell me what are your thoughts on what is wrong. We've kind of done that already, but does anyone else want to say anything about what they think is wrong with him? Do you think everything we've said is a load of rubbish? Do you think it's changed what you think about this pathophysiology? Do you think it's changed what you think about hemorrhage? Anyone else got anything to say about what's wrong with someone like this? Or any experience you want to share with us? Anything, any tips you want to give us? We're learning all the time. We're here to learn. We're not just here to like go on and on about what we have to teach. We're here to learn from you guys. There's a massive amount of experience here. Please tell us. Go on. Ah. Yes. Good question. The bunny rabbit. I did get a bunny rabbit out actually, Frank. You'll be glad to know. Because, well, we gave him some pain relief very early. If I'm honest, it was partly it wasn't really to take away his pain, it was to keep him still. Because initially he was agitated and restless and I wanted to get a femoral line in. I thought it might be my only chance, so I gave him a small amount of ketamine to keep him still, knowing that it will hopefully help his distress and pain as well. I told him, he asked me, am I going to die? Because we did all the stuff Frank talks about. We did say, this is life-threatening. You know, we have to do this to like help everyone focus on what's wrong. Guys, we're going to lose him if we don't move now, and we need to squeeze loads of blood. And I'm talking to my colleague saying, like, I don't know if we can put a balloon in him, he's too small, squeeze as much blood in as you can, phone a code red. He's in the ambulance, awake. The ketamine we gave him was small, so he recovered very quickly from that. And he hears me on the phone saying, I've got a code red, which means, you know, massive hemorrhage patient. He's critically injured. We need the whole team there. I think he's gone through his spleen and he needs an immediate transfer to theatre. So of course he said to me a number of times, am I going to die? I said to him, no. And you could say, I'm lying. If I was honest, I would have said, I'm really, really scared that you're going to die. But I don't see the point of telling him that. I kind of want his... I don't know if what's right or wrong. You can tell me what you think. If it was me or my brother or my son, I would want them to feel safe with me. And I would want them to just think, okay, everything's going to be all right. Keep hanging on. And I said, no, you're not going to die. In fact, I said to him, I promise you, absolutely promise you, you're not going to die. Definitely not. Not with us. Who thinks that's right or wrong? Anyone got any thoughts on that? Bunny rabbit or no bunny rabbit? Good. Thanks. Okay. What? Any other questions on any of this stuff? All right. What are you going to do? Has anyone changed their mind in what you're going to do? Because I think we all see splenic injuries. We all see people bleed to death from a spleen, and we all see people that don't bleed to death from a spleen, and we know how to manage them. You'll get your hand up. Well, how have we changed your mind on what you're going to do? Really? And what? And can you see the wide pulse pressure?
We didn't have invasive monitoring at a certain point. You ultimately lost pulses, but pulse pressure widened out to almost 90.
Really?
Yeah, as a diastolic in the 40s.
So in case, and for those who are watching online, in case you can't hear, remind me, you work in the States, is that right? So we've got a chap working in the States, pre-hospitally. Was this a penetrating injury or blunt injury? Blunt, okay. Someone with a blunt injury, and he's telling us that he's just heard what we've had to say, has looked back on the obs from this patient whom died in your hands, presumably, and you've now clocked he had a wide pulse pressure. That's amazing to hear, and it's interesting, and we still don't really know what it means, but that's exactly what I saw with this kid. I only clocked it once I've been told about it. So I don't know if anyone else has the ability to go back and look at patients, but if not, maybe we might look at it as we treat them going forward. Has it changed? Was that out of hospital or in hospital? Out of hospital. Has it changed what you think you would do for him? Is there another mic that we can pass around to people, or is that not possible? We've only got, don't worry, there's only 5 minutes left, but we'll just, rather than me repeat everything you say, can we pass you a mic?
I hope I don't make myself sound like a fool. Historically, I've not really believed in invasive monitoring, frankly, in the out-of-hospital world. I think that the practice seemed to sort of create a lot of delays. But I think that it's hard because as you have these sort of lived experiences, you start having a hard time. You feel like there's a vacuum of information. And you were going through the case, and this sounded rather familiar. And I kind of understand that for the majority and many patients, yeah, it doesn't make any sense. But there's that sort of subgroup of patients that it's hard to put your finger on sort of patient identification and all. That it's challenging with non-invasive to really be able to actually catch this, frankly.
Yeah, okay. So are you saying that you might, if you were doing that case again, you might prefer a system where you have invasive monitoring, blood pressure monitoring?
Yeah, and we are planning on doing it, but I had sort of some hesitations.
Yeah. Well, we've all got the same hesitations, and we've traditionally always said, "What are you doing? Get away with the art line. We need to go to theatre. It's ridiculous. You're wasting time. We know he's sick." And that's probably that's belittling the value of an art line, and why it's being done. But the reason we've actually started doing it is because we were putting it in to do Reboa, and we've learnt this side benefit of observing the physiology more accurately. So I don't really know whether the right answer is add invasive monitoring. Yeah. I don't know. If you're not going to do it as a means to an intervention. Because the reason we try and teach our teams, don't do it just because you're interested in the blood pressure. Do it because you may need to upscale to a balloon. However, I think you're right. There is also some gains to be had by just watching a more accurate blood pressure. The only challenge, I guess, is to say, do it but don't cause a delay, which is really hard. And we are constantly grilling ourselves and our teams, if you're going to do it, make it bloody quick. And give yourself maybe 5 minutes max to put the art line in, because we do a lot more art lines than we do balloons, much more art lines than we do balloons. And we're conscious of our scene times. The more complicated bits of kit you put in your toolkit, the more time you can potentially waste. And we are monitoring that closely. And actually, we may be seeing a trend towards longer scene times we're worried about. We're keeping an eye on that. So you've got to watch that carefully. What was I going to say about that? I was going to say, well, I think that's it. You've got to be careful about how long you spend doing it. But what about interventions-wise? Okay, does anyone... We won't make this all about you and your case. But does anyone else think it's changed what you think is the intervention for this person? Should we... Oh, thanks. I've now got a microphone assistant, sorry.
I really enjoyed your lecture here. Gentlemen, I think it's great to discuss physiology. I think you've really pushed us somewhat in order to understand what is going on in bleeding patients. But again, I would like to argue that in my mind, I would do the same. I would really prioritize all these patients that you have presented to us, they need a surgeon to stop the bleeding. So short sitting times or just load and treat while on the way. I would argue that we have a challenge here that we potentially can make too much scene times in some of these patients. Of course, if you are in a system where you have long scene times and so on, but for example, your HEMS patient had a scene time of 41 minutes as compared to a flight time of approximately 20 minutes. So sometimes we need to consider, is the interventions actually worth?
Yes.
Reboa is controversial. You have really pulled strong for Reboa. But again, I would argue to present what is the evidence to support Reboa currently. You are participating in the UK Reboa trial. In Denmark, we are not participating, but again, it's a challenge. The evidence do not support the use of Reboa, but many centers like yours is actually using it. So again, we need, again, potentially remember, do the basics right, start the good interventions that is evidence-based, get this patient to hospital and so on. So in my mind, it's a great way to discuss this, and you are moving ahead on many aspects. And Reboa potentially is something that we need to consider in the future. But again, I'm a little bit afraid about if we as anesthetists, emergency physicians, choose to spend too much time on scene during transport instead of just going the right place the first time.
Thank you. That's perfectly said. Now there's more hands up. We're probably going to have to continue the discussion into the restaurant, I think, because we're out of time. But thank you for saying that. That's a really important, massive side to the story, and it's all true. We've ourselves scrutinised our scene times, and we are petrified of doing it in the wrong patient, because we're asking our teams to predict who is going to die and who isn't going to die. And we say to our teams, you only do it if you think they're going to die. Well, how the hell do you know? It's difficult. Challenge number one. And then we're saying, it's complicated, use ultrasound, you put this into 25, 30 centimetres, that one 45 centimetres, you have to measure it here and there, you use a 4 French and 8 French. It's complicated, man, and it can add time, and it can distract you. And we have also had times where you can see that there's been a distraction from the intervention. However, the flip side to the story is that we've got a large cohort of patients that we know have not survived to hospital. And there is international, not just local evidence of that. And there are large case series, and there's a fellow called John Holcomb that summarised it quite nicely. The peak times in death in some of these people that don't survive from hemorrhage are often in the region of 30 to 40 minutes, which is, even if you're the quickest service in the world, even if you pick them up, chuck them in an ambulance and go to hospital, the scene times from injury to arrival in hospital is often around 45 minutes, even in London, if you're really quick and you do nothing. So there is a challenge there. Now, I don't know what the answer is, but we're trying to face that challenge because there are people that die. And we also try and teach our teams that if you, let's say we're talking about an art line or a balloon procedure, it should only take you 5, maybe 10 minutes max. That's challenging, and it adds a lot to your mental load. But I would argue if your patient can't tolerate 5 minutes extra time, would they have survived to hospital, or would they have died on the way? And I know that's not the whole story, because we can obviously spend a lot more time, and that's not the whole story, but that's the concept we're trying to get our heads around. And if it turns out that they weren't as bad as we thought, and we put in an art line and we wasted 5 minutes, then there's probably not much harm done. But it's not as simple as that. Look, we're going to have to carry on lots of this conversation as we go, but you're right, there's still a lot of evidence to generate. We are studying the cases very carefully. We are part of a UK randomised controlled trial in hospital. We're also part of a feasibility trial. We're running a feasibility trial and plan to do a lot more that these guys are leading on research-wise, and we're not taking it lightly by any means. So thank you. Can I just quickly, to summarise at the end, ask you four clever, kind, wonderful people to just give us one take-home point from everything we've just talked about over the last 2 hours. Look, we can pass a microphone around. So give us your one snappy take-home point that you want people to go away with.
I agree with your point, and I just, as I say in the conclusion for me, is stop the bleeding is the most important. Replace the volume. Get to definitive care quick. But do, in these very sick patients, consider the coronary perfusion. And I don't know what the future interventions hold, but we need to start thinking about it.
Yeah, I mean, again, following on from your point, the one thing that I struggle with is we have this group of patients who don't survive the hospital, so we need to identify pathophysiological clues and signs that allow us to decide which patients it is worth spending 30 minutes, which is a huge amount of time in this context, to allow them to arrive at definitive care in a salvageable state. So yeah, I think the key challenge for us moving forward is to really delve into that physiology to identify ways to stratify which patients would benefit from this type of interventional care and which weren't. And that's, it's important we do that in a robust way with prospective research.
Thank you.
Thanks. I would say tailor your training to your patient group and to the clinicians at work, and I think that's one of the things we're really trying to do. And the other thing that I would say is don't underestimate the importance of wide-bore venous access and early femoral arterial access, and do the rest of it. A lot of it can be done on the way, which leads into your point, as long as you've got those two things.
Frank?
Thank you. Rabbits are not just pets.
That can be interpreted in many ways, thank you. Thank you, guys. And I just want to say thank you again. It's been absolutely wonderful being here. It's wonderful meeting you all, and it will be wonderful for the next couple of days, I'm sure. We really appreciate coming out here. And thanks for teaching us stuff as well. It's not all about us telling you all of our stuff. So thank you. See you in the restaurant.